We're going to call the Pension and Health Committee meeting to order. First order of business to be to call a roll. Ms. Hopper, please.
Rob Fechner,
Good morning.
Margaret Brown,
Good morning.
Henry Jones,
Here.
David Miller,
Here.
Nicole Griffith for Irena Ortega,
Here.
Ramon Rubicava,
Present.
Teresa Taylor,
Here.
Shonda Wesley,
Here.
Karen Green Ross for Betty Yee.
Here.
Mr. Chair, I have all in attendance.
Thank you very much. We're now going to recess into closed session for items 1 through 3 from the closed session agenda. So this time, the board members will please exit this open session and connect to the closed session meeting. For those of the public that are listening, we will be back with open session after we finish our closed, after the Board Governors Committee meeting, and probably after lunch. So we will be back in open session, but it will be some time now. We'll see you all in closed session, board members.
I would like to call the Board Governance Committee meeting to order. And the first order of business is roll call, please. Ms. Hopper.
Henry Jones,
Here.
Rob Fechner,
Good morning.
Frank Ruffino for Fiona Ma.
Hi, Pam. It's Matt. I'm sitting in.
Okay, thank you, Matt. Matt Seha for Fiona Ma.
Present.
Lisa Middleton,
Present.
Stacy Oliveris,
Here.
and Irene Ortega.
Here.
Mr. President, all is in attendance for the Board Governance Committee.
Okay, thank you, Ms. Hopper. Next item on the agenda is approval of the June 15 Board Governance Committee timed agenda. Do I have a motion?
So moved.
Moved by Mr. Fechner, second by Mrs. Oliveris. Ms. Hopper, please call the roll.
Rob Fechner,
Aye.
Matthew Seha for Fiona Ma,
Aye.
Lisa Middleton,
Aye.
Stacy Oliveris,
Aye.
Irene Ortega.
Aye.
Mr. President, all ayes. A motion made by Rob Fechner, seconded by Stacy Oliveris for agenda item 2, approval of the June 15th Board Governance Committee timed agenda.
Thank you, Ms. Hopper. Next item is executive report. For that, I call on Mr. Jacobs.
Yes, good morning, Mr. Jones and board members. The agenda today contains 2 substantive items. 5A involves the discussion about whether to establish formal separation requirements that would preclude simultaneous holding by board members of certain board and committee leadership positions. And then 5B deals with whether to establish a formal rotation requirement or requirements for board and committee leadership positions. We have Ann Simpson and Rick Funston. I don't see them in there, so if they're in the waiting room, if you will, then they should be promoted to assist. They're here to assist in the discussion, as of course am I. And that is my executive report. Back to you, Mr. Jones.
Okay, thank you, Mr. Jacobs. The next item on the agenda is action consent items. It's 4A and 4B. And before we ask for a vote on it, I would just like to have the item 4B to make a comment on the CEO delegation resolution. Our annual approval of review and approval of delegations have been in place for, I guess, over 10 years now. And many times there's no substantive changes within a year. So I would like to give direction to Mr. Jacobs to bring back for consideration for the committee whether or not to have that done every other year as opposed to a single year. So the committee members can chime in as to whether or not they would like to move in that direction.
Very well.
So
We'll put that on the next Board Governance Committee agenda.
Okay, thank you. So with that, this is an action item on 4A and 4B. Do I have a motion?
Motion to approve.
Moved by Ms. Milton,
Second.
second by Mr. Fechner. Mrs. Hopper, please.
Rob Fechner,
Aye.
Matthew Seha for Fiona Ma,
Aye.
Lisa Middleton,
Aye.
Stacy Oliveris,
Aye.
Irene Ortega.
Aye.
Mr. President, I have a motion being made by Lisa Middleton, seconded by Rob Fechner on agenda items 4A and 4B.
Okay, thank you, Ms. Hopper. Now we move on to information agenda item 5. And when we met at our last governance committee meeting, the committee solicited board members' views on future committee agenda items. And there were 2 items that were suggested that are listed here as 5A and 5B. And so in the, after the discussion of that, I did reach out to Mr. Rick Funson, Advisory Services Group, and he prepared a one-page document that all committee members should have received by now. And on that document, the first three items on there, 1, 2, and 3, refer to 5B. And the next three items, 4, 5, and 6, refers to agenda item 5A. So as we go through the discussion, just note that the document that was prepared by Mr. Funson includes both of those agenda items. And so with that, I'm going to ask Mr. Funson to make any comments as a result of having submitted this for the committee's consideration. Mr. Funson, please.
Thank you, Mr. Chair and members of the committee. We had a very kind of quick conversation, Henry and I did on last Friday, where we discussed these issues. And over the weekend, I put together these notes, which are really our opinions on the various aspects of what you're considering with respect to the frequency of elections, whether there should be staggered terms or rotation limits, as the first examples. In each of these cases, it's hard to establish definitive peer data without further benchmarking. So it's based on our experience in dealing with other systems across the country. But ultimately, as we would say in all of these cases, it's obviously it's up to the governance committee and the board to determine what's in the best interests of CalPERS. Having said that, we're happy at the appropriate time to try and answer any questions you may have about what we've documented here, given the kind of the brief nature of the memo itself.
Okay, thank you. Okay, so let's deal with then 5A first, which is the leadership positions. And as I mentioned, that the document from Mr. Funson, that is item 4, 5, and 6 on the document. So are there any questions or comments from the board? Mr. Fechner.
Thank you, Mr. Chair. I appreciate the information that you solicited from Mr. Funston and that he has now provided with us. I just have to say that, I'm the one that brought this up last month. I wanted to look at industry best practices, especially if your board has a disciplinary piece to it, and that may perhaps go through the board governance committee. And since the board president provides that discipline, should there be two bites of the apple, so to speak? I just wanted to just put it all out there. And I was board president and chair of board governance when Rick brought this to us the last time, a number of years back. And after being there, I think I disagreed with it at the time, that it just felt like too much. Again, this has nothing to do with the person holding the position. In my mind, I'm looking for best practices for the positions in general. Should they be separated or not? So I just threw that out there to get some information and have a discussion about it. So that was my comment, Mr. President.
Thank you. Okay, Ms. Taylor?
No more board members or chair, committee members?
No, not at this time.
Okay, so I just wanted to, reading number 1, so I guess I don't disagree that there is a learning curve as you take these offices, and I'm hoping that later on in the document you talk about
Wrong item.
Okay.
Yeah, you talk about the training basically and succession planning for the board, and so I'm so you're considering it's common for peers to elect officers in one-year terms, and it's not uncommon for us to elect real.
Ms. Taylor, we're on 5A, and that the document for 5A is item 4, 5, and 6.
Oh, that I know you're not looking at 1. I thought I heard you say 1.
No, I indicated 5B relates to items 1, 2, and 3 on the Benson document. And item 5B relates to item 1.
4, 5, and 6. Okay, I'm sorry.
1, 2, and 3. Okay.
Okay, so I'll save those comments for later. The multiple chair responsibilities, I'm not sure that board governance and holding the presidency are always a good idea because it leads to a possible conflict. So that's my only comment on those, as well as on risk and audit. So I think that is my comment for that.
Okay, Ms. Middleton.
Thank you, Mr. President. Let me take 4, 5, and 6 in order and just simply offer a comment. The practice that we've had for a very long time has been for the president to make appointments to the committee. I think that's a very important responsibility. I do not see any reason to make a change, and Mr. Funston doesn't seem to be recommending that we make a change. So as to whether or not the president should also be the chair of the governance committee, the way I read this, Mr. Funston is essentially recommending that it can be done either way. I'm certainly comfortable with that. In many of the organizations that I've been a part of where there is a governance committee, the president or the chair of the organization plays a very active role in governance. And I think that's something that we should expect. As far as succession planning goes, I've had experience with a number of organizations where vice chairs are assumed to be the successor for the chair. And that assumption is always one that's up to an actual vote at the time that a chair's position becomes available. But that assumption that the vice president will move into to that position has been something I found to be very good for the consistency of organizations. Thank you.
Thank you, Ms. Milton. Ms. Oliveris.
I would love to get Ann Simpson's take on this as well, if possible. It's been my understanding from the corporate board perspective that typically the board president does not chair any committees.
Ms. Simpson?
Thank you very much, and good morning, everybody. Ms. Olivares is correct. And I think this goes back to the purpose of having a committee structure, which I know the board has discussed at some length on other occasions. But the whole purpose of the committee structure is that certain members of the board can do a deep dive. You get the first bite of the apple, as President Jones put it, in the committee. Then the committee comes to the full board to make a recommendation. Now, we do have a provision whereby if the board president who's presiding over that full board discussion is also a committee chair, then the vice chair takes on the report. However, I think it's fair to say that the general practice is in the corporate world that the chair of the board, or in our case, the president of the board, focuses on that prime responsibility for managing the board, which takes recommendations from the committees. Now, the exception to that, of course, is the investment committee, which has gone back to being a committee of the whole. But yes, it is really to allow that division of labour. However, it's important that the board develops an approach that fits CalPERS circumstances, because CalPERS is not a corporate board, it's a public body, and therefore there are different practices that need to apply because of the particular structure of CalPERS. Thanks.
Mr. Oliveris?
Thank you, Anne. So it's a little bit interesting when we look at some of the other public pension boards and how those are structured. And obviously within the United States, CalPERS is the largest. When we look at other large pensions of similar size globally or other large institutional funds, how are they structured in terms of their governance?
Would you like me to respond to that?
Yeah, please, Mr. Franson.
Yes, thank you. It's a great question. We don't have a comprehensive body of data that would actually look at that on a case-by-case basis quantitatively. Our impression is, though, that it really does vary by organization. Some, as I've said, do as Anne has suggested, which is that it is the president and the chair of the board really has a singular responsibility. Others have divided it up in a variety of different ways. We have seen in one case, which we recommended strongly against, where the chair of the board was also the chair of every committee, which was definitely an anomaly. The key, I think the key issue here is the issue of workload. Now, clearly, the president of the board of CalPERS has a significant workload, and we had at one time early on done a study and benchmarked that using CalPERS as an example, and we looked at the number of hours spent by the president and spent by by committee members respectively, and I believe it was 4 or 5. I'm just recalling from memory here, and I may stand to be corrected, but I believe it was 400 or 500 hours a year spent by the president of the board at the time, and that may be an underestimate, obviously, depending on the circumstances at the time. So that my long-winded answer to your question is, it really depends. It varies significantly across the board. And it may be worthwhile for you to consider looking at specifically a more updated review of what the current practices are among other large public retirement systems, both domestically and nationally. But again, it really does come down to a question of workload and what's practical. And in addition to the comments that I've said, there are also there are potential conflicts in dealing with audit risk and compliance as well as investment. The question is whether or not you would interpret there to be a similar problem with respect to governance. But there is no clear pattern at this point.
Thank you, Mr. Fenton. And Mr. Jones, I have one more question, and this is for Simpson. And when we're looking at key person risk, for example, and we just recently had a discussion regarding that, I'm wondering what practices we see with ICGN, ILPA, et cetera, on corporate governance and mitigating key person risk as it pertains to the president and chairing a committee. And again, these are not a reflection in any way of our current leadership, which is fantastic, but really making sure that we're thoughtful in setting the stage going forward.
No, thank you, Ms. Olivares. I would need to go off and speak with ILPA and ICGN. I'm not at the moment aware that they have guidance on both those issues. I believe ILPA does, but I don't have it to hand, but I would be glad to follow up.
Great, thank you.
Mr. Miller.
Thank you, Chair Jones. Just a couple quick comments. I share some of the concern about the potential for an issue to come before board governance of discipline where the president was the moving party. But I think in that case, it would be perfectly reasonable for the president to hand the gavel over to the vice chair if there was any concern about that among the president and the committee members. So I would not be opposed to the president continuing to continuing to have that as an option for the president to serve as the chair of that committee. The other thing I would kind of highlight from my perspective is one of the biggest differences between CalPERS and corporate boards is just the requirement that we do everything in public, except for restrictions to closed session, the whole Bagley-Keene environment. A very different environment versus a corporate board where the presidents, chairs of committees, committee members can meet in a much less restricted way, can discuss things, can coordinate things. And so for us, I think it's very important for the president as the leader of the board to have a lot of say about committee structure, who's on the committees, who chairs the committees, and where they feel their participation can be most beneficial as a leader of a committee potentially. So that's just my thoughts on that.
So are there any other requests to speak on this item? Okay, Ms. Taylor.
I just had a question. I can't remember if this was new. I'm thinking this was kind of new that the president started serving on the governance committee. Wasn't it with Priya, I think? And
No.
It was before that? It had happened before?
I think Rob had mentioned that he also served in both.
Okay. I don't remember when I was first on the board that whether or not Rob was chair of governance at the same time. I can't remember. I do remember one of the reasons that you and Priya continued, if that was a continuation, was that the committee was in charge of the self-evaluations, and there was a need to move those. So, and whatever results of those self-evaluations were. So I can see why that occurs. And I think also when I remember first being on the board, the governance committee didn't have a lot of items to deal with. So I don't know that I see any issues with holding this position or the president continuing to hold the governance committee chair. And like David said, if there's a disciplinary action that's coming up that the president needs to step back from, he can hand it to the vice chair. I think that was the only thing I was thinking would be a conflict is in case of that. But I can see where this could, I don't know why we're since it's been a common practice, are we trying, I guess my question is, are we trying to make this a permanent thing? Or is this just a discussion?
Well, the genesis of this is when we had our meeting last month, we had an item to solicit views of the committee members of what they wanted to discuss. And so this was one of those items that came up. And we're now responding to that request by having Mr. Funson provide some information, and Ms. Simpson is here also to provide information for discussion. This is not an action item, it's a discussion point. And what I've heard so far is that it's various viewpoints, but that appears to be a request for at least some additional information on the updated presentation in terms of other pension funds, and also from Ms. Simpson to report back on what limited partners and ICGN, what their structures are. So that's what I heard so far.
Do we know what CalPERS does?
I don't know. Ms. Packman, do you know? You're on that board over there sometime?
Yes, good morning. So at CalSTRS, the board chair does not serve as the chair of the governance committee. And we don't really have a formal policy about that at CalSTRS. It's just more out of practice. I think the thinking is that the job of the chair takes up quite a lot of time, and so didn't necessarily want to serve as chair of another committee. And also they wanted to kind of bring people along and do some succession planning and make sure that other members, once they are on the board for a couple of years, feel comfortable stepping into leadership roles, have that opportunity to do so.
Okay, thank you.
Okay, unless committee members have a strong opinion about this, we will just seek the additional information to have that reported back to the committee unless there's another viewpoint. Is that consistent with the committee thoughts? Okay, seeing no, no, seeing no additional requests for this, so that would be the direction of the chair. Okay, we will move now to item 5B, which is referenced in the document we received is items 1, 2, and 3. So, Mr. Funson, do you have any additional comments on those 3 items, or committee members, after you mention, we'll see if committee members have any questions?
I don't have any immediate comments. I'd be happy to answer any questions.
Okay. Are there any questions from the committee? Comments?
Mr. Middleton.
I see. Okay, I see no comments on this one. So if, unless there's an opposition, I would then seek to have an item come back to memorialize the fact that we will have a, and I don't know, maybe we should discuss if we're going to have a rotation, what is the views of the committee, whether that should be 4 years or 6 years before that rotation occurs. If you have any views on that, I would appreciate it. Mr. Fechner?
Yes, Mr. Chair, thank you. I'm not sure that we're to that point. It was an information item. We got the information and I wasn't prepared to go anywhere from where we were. So I don't know if you wanted to turn this into a future action item, bring it back as action on an agenda, but that's not what I thought this was. I thought this was information gathering, so maybe it was my mistake. But I'm not prepared to have that decision today.
Okay. Yeah, no, and I agree, Mr. Fechner. I wasn't looking for a decision today, but I just wanted to go get comments, ideas, so that when it does come back, that we would reflect what the committee views are. Mr. Miller?
Yeah, I would echo Mr. Fechner's comment. I did not see this as something. I thought strictly as information and thoughts, but I'm certainly not sold on any notion of rotations or terms or anything for committee leadership or anything. I think that still should be the purview of the president and the election by the members of the committees.
Okay, Ms. Middleton.
Thank you. I would concur with Mr. Miller and Mr. Fechner. I think this is very good information. I appreciate receiving it. I am not in a hurry to change our present practices.
Okay. Ms. Oliveris.
Thank you, Mr. Jones. I'd like to get additional information on this. So I agree this is something for our information right now, but I feel like it'd be helpful to have more information, and particularly for Mr. Funston and on what other pension plans do as standard practice with terms. And then from Ms. Simpson, again, from ILPA and ICGN, recognizing, of course, that there are best practices across industries and sectors, and I want to make sure that we are doing our best to structure the organization for success.
Okay. Are there any other questions or comments? Okay, so Ms. Oliveros, that request will be direction to bring back additional information as you requested so that we could see what the best practices are from the Funson's review and also from IPLA and the ICGN, Ms. Simpson. We can coordinate those efforts to bring back that information for further review.
Thank you.
Is that a summary? Okay, I see. Oh, Ms. Taylor?
So where are we going? Are we? What are we doing?
We're not recommending at this time to bring back any action item. We're seeking additional information regarding best practices on this area, and also to have Ms. Simpson take a look at what some of the other associations policies are surrounding this issue, like IPLA and ICGN.
So, Mr. Funston, I'm not looking at your information here. Just a quick question. If there's a term limit, say 2 years, which is what your recommendation is, 2 to 3 years, it looks like, is that still up for election, or is it just a, hey, Jay, we're saying that president can be up to 2 or 3 years, but then they have to drop off and let somebody else, or can it be still whether or not we elect that person every year?
Thank you. It's a good question. I think the first thing was the issue of the frequency of elections. They're currently annual. So the suggestion is, and this is fairly common practice, as we pointed out, that can lead to churn and very short learning curves. Again, so the suggestion was to consider extending that, and rather than having them annually, have them every 2 years. The third point, which related to rotation limits, would basically be that after serving 2 or potentially 3 2-year terms, then you would basically be timed out and be required to take a break from that before you could be considered eligible for re-election to that office. So that's the intention of the difference between the two. And the second point related to staggering the terms so that there isn't suddenly a major turnover in an election, annual election cycle to improve the stability of the board. Now, as we said earlier, there is no, we don't have quantitative information to support that. That's our opinion based on our understanding of what's prevailing in leading practice today. And as was suggested, further research is required, and we're happy to look at that more closely.
Yeah, because as I understand it, CalSTRS does something entirely different. Our elections are annually, and I haven't seen us toss somebody out in a year, and we have our own unfortunate churn, which is our elections, our actual elections from the members. So we lose board members unexpectedly all the time. So I'm not sure that putting it into, so I would rather see this as I don't know that we have a need for this. We have never demonstrated that we just throw somebody out after a year of serving in a chair position or a president position or vice president position. But we also, I think it's important that we retain the right to do so if something goes wrong. Because otherwise you're saying that this person could have rotation limits of 2 to 3 terms, but at the same time can be there for a total of 6 years. And that ends up being an expectation, and then people don't vote against that. So I think letting us vote and make that decision is important for us. But again, we can continue to discuss that, and maybe we should look at Lynn, you know what the practice of STRS is, but as I understand it, they self-rotate like annually from vice president to president, or chair to chair, vice chair. Is that correct?
No, there is annual elections for the chair and vice chair of the board, and then the committee chairs are appointed by the leadership of the board. And so they don't switch off every year, Teresa, but I think that in general, they probably serve 2 to 3 years at a time as being the board chair, unless there's an extenuating circumstance that comes up.
Okay, that makes sense. So yeah, that's what I couldn't remember if it was a couple of years or not, but I know that I've talked to Sharon a couple of times, and she was chair and now she's vice chair. So yeah, I just think retaining that, if you get someone as president that you've elected and they just and I'm not saying anything about Henry by any means. I'm thinking ahead, right? So say you get somebody in office that everybody thinks, okay, yeah, that'd be a great president, and then they just don't do the job because either something else comes up for them, or they get sick, or they can't do the job well. I think we should retain the right to be able to throw them out. So maybe if we consider it at the same time we consider allowing the annual elections, that might be
right. Well, Ms. Taylor, let me comment on this one, because as we sought committee member views, this was my suggestion to look at this. And let me explain what I had in mind. That we, notwithstanding the 2-year term, as Mr. Funson indicated, but my comments at the time was that we will continue to have annual elections for the president, for the chairs, and the vice chairs. That will continue to be an annual election process. What my thought was that even if you were elected 6 years in a row, the 6th year, let's say 6 or 7 or 8, whatever the case may be, then you would rotate out of those roles. And you would be in a dark period for 2 years. And then if you stay reelected to your position, as you mentioned, on an ongoing basis, then you would be able to come back into that role as president, chair. Right? So we're not, my comment wasn't to remove the annual election. Mr. Funson suggested maybe rather than annual election be election for 2 years. So in that scenario, you would elect the chair, the vice chairs, president every 2 years, but you still at the 6-year period, you would then rotate out of that role. So that was my thoughts about this item.
Forgot how to unmute for a second. Thank you. I appreciate that. I was just a little confused. I think, I don't know that we even need that. Like, I understand the idea of churn, but I think that we are a bunch of folks that work cooperatively with each other, and I think we can understand when we can decide, even annually, if the president should continue to serve. So I think if we set that expectation that, you have 2 years, or you have 4 years, or you have 6 years, even if we still have elections, it sort of sets an expectation that, oh, well, we have to vote for this person every single time. I'm a little concerned about the expectation, because we kind of, CalPERS kind of steeps itself in tradition and expectations, right? There's this kind of old tradition. Okay, well, so-and-so has been president for this long. Henry, you're president. We expect you to be president for this long. So I get it. I see what you're saying. So you're saying not to get rid of the 1-year elections, or maybe change it to 2, but maximum is 6, so that nobody sits in the presidency for a long time.
Yes, that was the thought. Mr. Miller? You're muted, Mr. Miller.
Sorry about that, the dreaded double mute. I appreciate the information. I appreciate Mr. Funston's thoughts on this, as well as Ann's, but it seems to me this is a little bit of a, solutions looking for a problem. I'm still not seeing that there's been a problem with our current practices. And I think, the board has, and hopefully will continue to choose the leaders on these annual basis that we feel are the best individuals to sit in those leadership roles, and that the president will continue to appoint the best choices, those committee chair, and those committees will continue to choose the best person among them for those leadership roles within the committees. So I'm just still not seeing that there's anything that I feel would be compelling to go in and start making wholesale changes to any of these things, absent some real indication that we've had a problem or will have a problem. I don't foresee that.
Okay, I think we got a sense of the committee and board members' views on this, but I think it still would be helpful to get that additional information and for the board members as Ms. Oliveris requested. So are there any other comments on this item? Okay, seeing none, we will move on to summary of committee direction. Mr. Jacobs.
Yes. A couple of things. First, agendize whether to change the annual review for the next board governance committee, whether to change the annual review of committee delegations to biannual or something of that ilk, and then return or obtain additional information about the items we've been discussed in 5A and 5B from organizations like ICGN and ILPA and other pension funds. Report those back. Now, my question is, did you want those two back on the agenda, or did you just want Mr. Funston, Ms. Simpson to obtain that information and communicate it to the board members?
Yeah, why don't we just obtain it and communicate it back to the board members? And if the board members have a different viewpoint going forward, then we'll agendize it then. But just provide the information as requested.
Very good.
Okay. Now we need to, is that it, Mr. Jacobs? I think so, right?
That is it, yes.
Okay, so do we have any public comment? Mr. Fox? Okay, I think I see a note from Ms. Ortega said no public comment, so is that correct?
That's correct.
Okay.
That's correct, Mr. President.
Okay, well then, thank you, and that would conclude this meeting. And Mr. Fechner, is it your next meeting? What time?
It is, and right now, I mean, we know we need to give the stakeholders time to digest the rates that they've just gotten. So why don't we say 12:45? That gives them an hour and a half to go through that. Does that work for everyone?
Yes.
All right, 12:45, we will start with Health Open. Thank you.
Okay, thank you, and this meeting is adjourned. Thank you.
everybody. Looks like we're still waiting for a couple of board members, so we'll give them a minute or so here. Welcome back, everyone. We are continuing the open session. We've adjourned the closed session. We're on item 2 of the open session, which would be to approve the timed agenda of June 15th. What's the pleasure of the committee?
So moved.
Is there a second?
Second.
Okay. Moved by Mr. Miller, seconded by Ms. Taylor. Any discussion on the motion? Seeing none. Ms. Hopper, please call the roll.
Margaret Brown,
Aye.
Henry Jones,
Aye.
David Miller,
Aye.
Nicole Griffith for Irena Ortega,
Aye.
Ramon Rubalcaba. Don't see him yet. Teresa Taylor,
Aye.
Shonda Wesley,
Aye.
Karen Green Ross for Betty Yee.
Aye.
Mr. Chair, I have a motion being made by David Miller, seconded by Teresa Taylor. All ayes. As of yet, I do not see Ramon Rubalcaba in, and that is on agenda item 2, pension health timed agenda.
Very good, thank you. Brings us to agenda item 3, the executive report. Mr. Mould, Mr. Sweeney, who's going first today?
I'll be going first, Mr. Chair.
Very good.
You ready for me?
We are. Go right ahead, sir.
All right. Good morning. Good afternoon, Mr. Chair and members of the committee. Anthony Sweeney, CalPERS team member, and it's great to see you all again. While this has been a repetitive theme of mine at the top of my updates, I'm happy to continue to report that our benefit payments are still being processed in a timely manner, and our customer service and satisfaction levels remain very high across all our processes within the customer services and support branch. We continue to monitor retirement trends to help us manage our workload, and we remain fairly steady in the first quarter of 2021 compared to this same time last year. And that's across all our employer sectors, state, public agencies, and schools. Focusing on the education of our members, we continue to explore our options for best serving them in a hybrid environment going forward. In the meantime, we continue our virtual counseling appointments and have completed more than 15,000 virtual appointments since we last met in March. Those are mainly conducted by phone, but we're also able to accommodate video appointments if the member chooses. We are currently planning outreach to our members to help assess our future delivery model. We're asking them their technical capabilities, how far they are willing to travel for services, and ultimately what type of delivery they prefer. While we have had great success in the virtual environment and we know it will continue in some fashion, member preferences will ultimately drive our delivery model into the future. Shortly after I gave my last update in March, we delivered our third virtual CalPERS benefit education event. At that event, we unveiled new enhancements, including an interactive information center that allowed members to connect directly with the experts for live questions, and a resource center that provided a variety of topic-specific informational materials that they could download and review at their convenience. We offered 20 classes over 2 days that attracted nearly 5,000 attendees, the majority of which attended both days. And satisfaction ratings for the classes and the overall event were in the high 90th percentile, and our website data shows an encouraging trend that the members stayed engaged with the resources provided online and took the time to explore them more on their own after the event. Our next virtual event is slated for December, and we're making plans to conduct a blend of in-person and virtual events next year. I know our members appreciate seeing many of our board members at those in-person events, so we'll look forward to seeing you there in 2022. As I shared back in March, we have some great new online functionality related to service credit purchases. We've enabled members to calculate the cost of a service credit purchase and elect it from their member self-service account. The easy-to-use online method guides members through a questionnaire based on their CalPERS account information and appointment details. It displays which service credit types they may be able to purchase. In the first 4 months of implementation, 36% of costing requests received were electronically submitted by members, including one by myself as well, so I can attest to the ease. When it comes to electing the service credit purchase, our members are now able to do so online, and that eliminates the paper-generated election packet and associated postage costs. In the first month after implementation, 45% of all elections were electronically submitted by members. And then they're able to make payments using our electronic payment gateway, eliminating the need for paper checks to be mailed to us. So they can choose to pay by credit card or ACH deduction from their bank account. As we've begun planning for next fiscal year, we're looking at additional customer service enhancements and providing more tools and online resources for our members. Before I close, I just wanted to share a story about how our teams work to assist our public servants in times of tragedy. Whenever our survivor benefits team is alerted about a tragic event involving any public servant who might be a CalPERS member, the team reviews all available information so they can provide the best service possible to the employer and to the survivors to facilitate the processing of benefits. When the team learned of the recent shooting involving the Santa Clara Valley Transportation Authority in San Jose, they reviewed the accounts and contracts of each of the public servants. And while most of the victims were part of a different retirement plan offered by the agency, we did identify one victim as a CalPERS member. We were able to work closely with the VTA and the member's family to process those benefits. Unfortunately, this isn't the only tragic event of this kind this year. Just this year, we've experienced other officer deaths in Santa Cruz, Stockton, and San Luis Obispo, and those were also immediately triaged in a similar fashion. While we hope these types of events are minimal, I'm extremely thankful and proud of how this team handles these situations. So much of our work right now is focused on the return to office plan and on what a hybrid team and telework environment looks like, and how we continue to focus on hybrid education to serve our customers. I want to again thank our team for all they've done to continue their exceptional customer service during these unprecedented times, and thank them for their patience and understanding as we work through our return to office plan. And thank you to the board for your continuous support. That ends my presentation, and I'm happy to take any questions.
Thank you, Mr. Sweeney. And I, too, on behalf of the committee, want to thank you and your staff for the exceptional customer service. I've heard during the pandemic times that customer service and response times have actually improved. So people are very, very proud to call that work being done. So thank you and your team for a job well done. And we certainly hope that you don't have to do any more of these fallen officers and members. It's been way too many this year. Seeing no other requests, thank you. We'll move to Mr. Molds.
Thank you.
Good afternoon, Mr. Chair and members of the committee. Don Molds, Chief Health Director. I'll start by sharing some good news. First, CalPERS and our own Dr. Logan were recently recognized as part of statewide collaborative efforts that decreased elective C-section rates. A study was just published in the Journal of the American Medical Association, highlighting how the collective work of several coordinated programs helped to reduce the number of C-sections for low-risk first-time mothers. The study was led by Stanford University School of Medicine and the California Maternal Quality Care Collaborative. It examined efforts across the state between 2015 and 2019 and led to California becoming the first state in the country to achieve a sustained reduction in C-section rates. CalPERS was involved through our prior strategic plan in collaboration with Smart Care California, and Julia was involved during her time at the Department of Healthcare Services, where she worked on hospital incentive programs to decrease elective C-sections. This recognition demonstrates how our collective efforts with other purchasers can make a big impact. The second piece of good news is that we are launching the first cohort of the CalPERS Healthcare Academy this summer. The Academy CalPERS team members to become more informed about healthcare markets, policy, purchasing trends, and their implications for CalPERS. Marion Mulkey, who you may recall delivered the health education session to the board in January, created the curriculum and will lead the sessions. This is all an outcome from the grant we received last year from the California Healthcare Foundation to develop a health policy training curriculum for the board and for our team. We're excited to kick off this first cohort later this summer and look forward to providing this excellent professional development opportunity to many more on the team. Next, I want to provide a brief update on our long-term care communications. As you're aware, we mailed the notification letters about the rate increase to policyholders at the end of May. As you can expect, we have been receiving calls and emails and letters, as well as posts on CalPERS social media channels. We prepared for this. Our third-party administrators call center added staff to handle the additional load and is reporting that the call center wait times are under a minute. So far, their daily average number of calls is up about 23% from average, which is manageable. The offer letters to policyholders to modify their coverage to offset the rate increase will be mailed starting July 26th. We expect to see high call volumes then and our staff to work with policyholders as they consider their offers. Last, before I turn things over to Marta Green to lead us through the discussion of rates, I want to say a little bit more about spending trends. Going into this year, we anticipated significantly higher than usual medical costs for 2022. Our projection at this point last year was that there would be a steep decline in utilization throughout 2020 that would last through the first quarter of 2021. This was anticipated due to COVID restrictions. Recall that for significant portions of 2020, hospitals and other medical facilities were shuttered for in-person, non-emergent care. Even when they were open, many people were reluctant to enter hospitals and doctors' offices. We anticipated the decrease in utilization would be followed by a spike in utilization in the second half of 2021 and throughout 2022 as vaccines started coming online and our members were able to receive the routine care that they deferred during the worst parts of the pandemic. While this is more or less the overall medical trend that we are seeing, it is far more modest than anticipated. The steep decline in utilization we saw in the spring of 2020 because of COVID returned to near normal levels far earlier than expected, particularly in our PPO. We still expect an increase in claims experience in 2022 as members seek delayed and deferred care, but our projections and the projections of our plans are that the increase will be far more modest than initially expected. More concerning are the pharmacy trends that we've been seeing headed into 2022. The overall price of drugs continued to increase in 2020, and drug rebates were generally lower. The transition to our new acquisition-based contract with our pharmaceutical benefit manager, Optum Rx, has also been bumpy. Optum's initial rate submission for 2022 included increases that were well above trend. About 4% of that increase was attributable to an under projection of 2020 utilization, with which we agree. However, a significant amount of the increase was due to initial disagreements between Optum and CalPERS about the way in which our savings guarantees in the new contract were intended to work. After reviewing and rejecting multiple subsequent Optum proposals, CalPERS moved forward last week with its own rate. Marta will go into much more detail, but our own projection is closer to typical pharmaceutical cost growth, plus the 4% we need to account for in 2020 projection. Encouragingly, Optum recently submitted a revised rate that is close to the CalPERS projection. That's the good news. The bad news is that we are very far off from what we want to be paying for pharmaceuticals. And for at least this year, the new acquisition price-based contract we have with Optum doesn't appear to be realizing the savings we had hoped for. As I said, Marta's going to go into much more detail on both the medical and pharmacy trends. I want to thank her for leading a good discussion this morning in closed session, as well as for the hour-plus discussion she led with our stakeholders that concluded earlier this morning. Her and her team have been burning the midnight oil, as they say. That concludes my remarks. I'm happy to answer any questions now. Otherwise, Marta and I will both be around at the conclusion of her presentation.
Thank you. I assume no request to speak from the board or the committee. However, I understand that we have some public comment. Mr. Fox?
Yes, Mr. Chair, we have 4 persons wanting to speak to long-term care, the first of which will be Tim Behrens, CSR.
Thank you, sir. Chairman Fechner, members of the committee, Tim Behrens, President of the California State Retirees. I'd like to speak about the continued increase in long-term care. Over the last few months, and since the rate increase letters were received, I have begun getting a lot of numbers of members contacting me and indicating that they can't afford such a large premium increase on top of a prior large increase and are likely to cancel their long-term care policy. To retain the same premium, they are concerned they will be getting a much inferior policy coverage. CSR has commented to the board on 2 prior occasions requesting staff to do a new actuarial analysis with more current data based on the impacts of COVID-19. Almost all the current data in the commercial LTC market suggests a combination of high mortality in skilled nursing homes, high mortality in the elder population, not yet in long-term care, and the reluctance of those who need skilled nursing but avoided it out of fear have contributed to much lower costs for long-term care funds. We have no expectations any longer that CalPERS might reduce the 52% increase they're implementing at this time, but based on that data that's lagging about 6 months behind and the new data of how many people will actually drop their long-term care policies, we hope to see that the 25% increase will be eliminated next year. Thank you.
Thank you. Mr. Fox, please.
The next caller is Larry Woodson with SR.
Good afternoon, Larry Woodson, Chair of the Health Benefits Committee, CSR. Can you hear me okay?
Yes, sir.
Okay. I'd like to thank you, Chairman Fechner, for the opportunity to comment. I'm commenting as well on the long-term care letters and the FAQs. I, too, received calls and emails from our members regarding the huge increase. Some are leaning towards dropping that I've talked to. Some after spending thousands of dollars over 20 years or more. If large numbers of people do drop, the high lapse rate would represent a boost to the fund, of course, and since it would retain millions and not have to fund any of those members long-term care. And I've heard from some members that are very cynical that may be the motivation behind this, and I don't believe that, but that is out there. I'm advising members to wait and see what individual offers are made then. I thought it would be in August. It sounds like it's in late July now, to retain the same premiums with reduced benefits. The letter of rate increase I received included the FAQ better explained the increases in the process, but it contained what I consider a highly inaccurate statement. It says, quote, the CalPERS long-term care fund is 69% funded and faces a shortfall of $2.1 billion. And I emphasize is, because that is based on a valuation report with 2-year-old data, and the latest status of the fund, which I obtained from Mr. Bienvenu recently, shows an increase in that fund of total assets, an increase of 12% over that time. And it really should be about a $1.4 billion shortfall, not 2.1. And combining that, the higher fund assets now with lower claims due to COVID, higher mortality in nursing homes and skilled nursing centers, the cost should have been greatly reduced and the fund in much better shape. And even the 2019 valuation report shows an investment return of 7.1%, well over the 5.25 discount rate, which was at the time. And it remains puzzling to me why the discount rate was lowered to 4.75. That lowering was a large driver of the 52% increase. Finally, CSR has no illusions that the 52% increase will be lowered, but we submit that there is ample current data available, including higher returns from global equity over the last year, which is the second highest asset class for the fund, to prevent any increase next year. And we submit there's justification for actually lowering the premium next year. Thank you for your time.
Thank you. Mr. Fox?
Mr. Chair, the next speaker is Mr. Lawrence Grossman.
Mr. Chair, members of the committee, my name is Lawrence Grossman. I'm a CalPERS long-term care policy holder. The premium on my policy since 2002 has increased 421%. The contract stated that the premium was designed and partly guaranteed not to increase. Now CalPERS is raising premiums another 90%, and my premium will be 890% higher than at inception. My policy, I believe, is exemplary of about 100,000 policies. Though CalPERS explains that these increases are normal for the industry and legal, those assertions are not accurate. During the past 2 decades, the federal long-term care insurance program reports rate increases of no more than 157%. Commercial insurers in California, such as Mutual of Omaha, Transamerica, and Thrivent, report increases no greater than 59%. 2 court rulings have declared that significant parts of past CalPERS rate increases violate policy contracts. CalPERS long-term care insurance program is, in my estimation, substantively insolvent. CalPERS' refusal to recognize this has led to a cruel and cynical strategy of extorting elderly policyholders. CalPERS gets away with this only because it is unregulated. This abusive behavior is precisely why insurance companies are normally regulated. If CalPERS long-term care program were a commercial insurance policy, by now the Department of Insurance surely would have declared it insolvent and placed it into receivership. Though buyers of these policies were never told, unlike regulated insurers, CalPERS is shielded from consumer protection oversight by the Department of Insurance, including approval of rate increases, and is not financially backed by state insurance guarantee associations that assist policyholders when insurers go bankrupt. Moreover, contrary to the understanding of policy buyers, there was no disclosure that CalPERS as a whole is not financially backing the program. At this committee's November 2020 meeting approving premium increases, there was no opposition and no substantive discussion. Today, I challenge each of you board members to explain your votes by addressing these 4 questions. Why are these rate increases fair to policyholders? Why have CalPERS premium increases been vastly greater than those of other carriers? Why did this committee not oppose, why did anyone not oppose the premium increase in light of the court decisions? And finally, why did CalPERS fail to disclose vital financial stability information to policyholders? At this point, this is what I think CalPERS needs to do. Acknowledge the program is insolvent, halt the premium increases, implement an independent program assessment, and 4, call on the state to rescue the program. State legislation created the program, and now the state should protect policyholders that they strongly encouraged to buy these CalPERS policies. For additional information, please Google the words CalPERS and Grossman, and you will find articles in detail that I have written on this subject. Thank you very much.
Thank you. Mr. Fox.
Yes, Mr. Chair, the final call on this subject is Mr. Alvin Barrett.
Good afternoon.
Good afternoon.
I'm Alvin Barrett. Thank you for listening. Thank you for taking my call. I have been a long-term care premium payer since 2004. My wife has been a long-term care premium payer for 26 years. Both of us have a substantial investment in the plan. When my wife subscribed, she was not told that her premiums were likely to increase, and they have increased several hundred% over the time while she's been paying them. We are faced with the prospect of another 52% increase, and these increases have been based on assumptions that we think are very questionable. This leaves us with a grisly choice of choosing between medical indications were we to need the services or having to abandon our substantial investment. We wish that you would analyze and reanalyze your assumptions. Your actuarial assumptions do not seem to be based upon recent experience with the pandemic and following that trend. We think that there are fewer persons relying upon nursing home treatment since the onset of the pandemic. We think the mortality rate has increased and probably will leave you with some benefits unclaimed. These circumstances lead to a conclusion that the cost should be lower than assumed under your actuarial analysis. We expect, in fact, a decrease in utilization in the near future rather than a more modest increase. We ask you to authorize an internal audit that would bring light on your actuarial assumptions and permit us to determine what likely ought to be done with our substantial investment in the future. Thank you for your attention.
Thank you. Ms. Brown.
Thank you, Mr. Chair. For the record, I did not support the increase back in November, but I also did not vote no. I abstained because I knew what a hardship this increase was going to be. I really do, and at that time, or maybe I did in April, asked for an update to the actuarial assumptions to see if we could lower some of the costs. Since that time, I have read a number of Mr. Grossman's papers he's written, and I have talked to him, and I believe I agree with Mr. Grossman about what CalPERS' next step should be, that we should get some help. We should ask the legislature for help, and we should delay the 52, 53% increase. We are giving our policyholders, and we're putting them in an untenable situation. And I think we need to relook at how we're handling this. I don't know if there's going to be a second on any of this, or this is even a motion, but I really think we need to do something different and go in a different direction. Thank you.
Thank you. I understand we have one more caller, Mr. Fox.
Yes, Mr. Chair, we have one more caller on this subject, Susan Cohen.
Hi, my name is Susan Cohen. I'm a CalPERS retiree, and I really appreciate your time and allowing me to present today. My comments will be very brief. I was a county department head, which means I was fairly well paid when the offer came to me in my late 40s. Two companies were offered, CalPERS and a private company. I thought, well, CalPERS, of course I want the CalPERS long-term care program. I don't have children. Why would I, if I did, burden them with my care anyway? I paid extra for the COLA increases. In 2013, the 86% increase was shocking, but I stayed with it. You know, it's CalPERS. Don't we all believe in CalPERS? I don't know what the details of the analysis that CalPERS did then were, but I do believe that you're repeating yourself. I believe that the rate increases are cruel. They don't line up with the contracts. They're really unfathomable, inexcusable. I don't think it's professional. Lawrence Grossman already spoke about the Department of Insurance review, but I want to personalize it. Besides that, CalPERS long-term care isn't regulated like all other long-term care programs. It is an unfair business practice. And so just to personalize it, and I won't be speaking much longer, I am looking at this rate of increase, 100, and I was a department head, so I was, you know, not the most high paid, but I was doing pretty good. I am looking at 100% of my retiree income being needed to pay the premium when I turn age 91. Now, I'm the daughter of a 100-year-old mother. I may not live that long, but should I be so lucky, and should I live in assisted living sometime after that, I will tell you that the premium will cover, well, obviously, if I'm on claim, I won't pay a premium, but the premium up to that point will take 100% of my retiree paycheck. And if I'm on claim, the benefit will cover half of my cost of assisted living, but I won't have an income. I believe that your continuation of this program as you're running it is immoral. I think it questions your ability to show respect to retirees, and I'm only pushing 70. The people who are 80 and 90 are really in a pickle. I believe that there should be an independent review. I do not know what all the costs are that your long-term care program has, all the costs, and I believe that the rate increases should be fully transparent and all of the costs should be revealed. And I thank you very much for your time and attention.
Thank you. Any other callers, Mr. Fox?
No, Mr. Chair, that concludes comment on item 3.
Thank you. Takes us to item 4, action consent items. We have one item in front of us, is the approval of the March 16th meeting minutes. What's the pleasure of the committee?
Move approval.
Second.
Moved by Mr. Miller, seconded by Ms. Brown. Any discussion on the motion? Seeing none, Ms. Hopper, please call the roll.
Margaret Brown,
Aye.
Henry Jones,
Aye.
David Miller,
Aye.
Nicole Griffith Ferreira Ortega,
Aye.
Ramon Rubalcava,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley,
Aye.
Karen Greenross for Betty Yee.
Aye.
Mr. Chair, I have all ayes for agenda item 4A, March 16th, 2021 Pension and Health meeting minutes. Motion made by David Miller, seconded by Margaret Brown.
Thank you. Agenda item 5 is the information consent item. Having no request to move anything, we will move to item 6, information agenda item 6A, preliminary 2022 health maintenance organization and preferred provider plan rates. Mr. Molds.
Thank you, Mr. Chair. I'm going to turn things over to Ms. Green to lead us through the discussion of the 2022 rates.
Thank you, Dr. Molds, and good afternoon, Mr. Chair and members of the committee. Marta Green, CalPERS team member. Next slide, please. Here is today's agenda. I'll review program updates for the 2022 plan year, the rate development timeline, discuss the weighted average preliminary premium changes, and explain the 2022 cost influencers, and present the preliminary premiums for the HMO and PPO plans. Next slide, please. I'll begin with a review of the number of changes approved for the 2022 plan year. First, CalPERS is portfolio rating the basic portfolio. This change is a result of a year-long analysis to manage risk and stabilize the basic plan portfolio. Plans will be priced based on their risk, plans will be priced based on their value rather than their concentration of healthy or unhealthy lives. We are implementing as a 2-year phase-in. As a reminder, Medicare plans are not included in portfolio rating, as the Medicare program is already risk adjusted. Further, the PPO program is moving from a 3-plan model to a 2-plan model, PERS Platinum and PERS Gold. Additionally, the board approved new plans, service area expansions, and supplemental benefits. In the basic portfolio, United Healthcare is offering a new HMO product called Harmony. Blue Shield is expanding Access Plus, EPO, and Trio, and Western Health Advantage is expanding its HMO product. In the Medicare program, we have 3 new Medicare Advantage plans from Blue Shield, United Healthcare, and Western Health Advantage. Anthem Medicare Preferred is expanding their service area statewide. Additionally, back in November, the board approved United Healthcare's proposal to reduce to 0 copays for many services, including emergency room visits. CalPERS gave the other health plan carriers an opportunity to propose changes to their Medicare copays for 2022. Blue Shield, Sharp, and Western Health Advantage proposed $0 copays for their Medicare plans except for emergency room visits. The emergency room copays will remain unchanged for these plans at $50 per visit. Next slide, please. Here is the rate development timeline for the 2022 plan year. As mentioned, last November, the board approved the new risk mitigation strategies for the CalPERS basic portfolio, and in November, in March, the results of the competition model approved new plans and service area expansions for both the basic and Medicare products. In May closed session, we presented you the initial premiums for 2022. Today, I'll present the 2022 preliminary premiums, which included the new program changes. Between now and July, the CalPERS team will continue to verify that all rates reasonably reflect the cost of benefits provided. Final premiums will be presented to the board for approval at the July offsite. Next slide, please. Let's start with the basic HMO plans. As I mentioned, these premiums are portfolio rated with a 2-year phase-in beginning in 2022. The CalPERS risk mitigation process uses a front-end premium adjustment process that is revenue neutral. Therefore, portfolio rating has no overall premium impact to the basic program. We also applied healthcare fund premium adjustments based on our healthcare fund reserve policy. In the table, you will see the preliminary 2022 proposed premiums for basic HMO plans with and without the recommended healthcare fund adjustments. Overall, basic HMO plans have a 5.53% premium increase before applying healthcare fund adjustments and a 4.83% with healthcare fund adjustments. United Healthcare's Harmony is a new plan, so it is not included in the overall premium increase. More details will be discussed on the plan-specific slides. I also want to address the adjustment period we are seeing as we transition to portfolio rating. As I mentioned before, the overall process of rating risk neutrally is revenue neutral, which means it has no overall impact to the portfolio. But what it does do is address pricing in individual plans. Those products that have seen skyrocketing costs year over year will reduce or moderate, while those that are chronically underpriced, well below the cost of healthcare and below the state contribution, will increase this year. But even with these increases, products like Salute-Mas will remain below the state contribution and hundreds below Kaiser, often cited as our benchmark plan. Once portfolio rating is fully implemented in 2023, we can anticipate smooth and predictable changes across the portfolio as adverse selection is fully mitigated. Next slide, please. For the basic PPO plans, this table shows the premium changes from PERS Care and PERS Choice to PERS Platinum and from PERS Select to PERS Gold. Overall, basic PPO plans have a 10.96% increase and an 8.31% increase with healthcare fund adjustments. For additional context, the PERS Platinum premium with healthcare fund adjustment is about $29 or 3% lower compared to what we presented in November when the risk mitigation strategy was approved. PERS Gold premium is about $4 or 0.6% lower. As you can see, the PPO increases are significantly higher than the HMO, and there are several contributing factors, including fee-for-service medical trend and pharmaceutical costs. I'll get into more detail on later slides. Next slide, please. For the Medicare Advantage plans, we have 3 new plans starting in 2022. For the existing plans, we see an overall decrease of 6.11% and a 6.40% decrease with the recommended healthcare fund adjustment for Anthem Medicare Preferred. I'll note here that the increase for Sharp's Medicare plan is due to the small plan size. It has only 68 members, and its pricing will stabilize as the plan size grows. It remains the lowest cost Medicare Advantage product in the portfolio. Next slide, please. The Medicare supplement plans see an overall premium increase of 10.07% without healthcare fund adjustments and 6.16% with recommended healthcare fund adjustments. Next slide, please. For the overall program, preliminary premiums have a 6.21% increase, and with the recommended healthcare fund adjustments, a 4.92% increase. Next slide, please. I want to talk about a few highlights that are impacting healthcare costs in our program. First, I'll update you on the COVID experience in 2020 and the expectations for 2021 and 2022. Then I'll talk about the preliminary pharmacy increases for 2022. Lastly, I will give you an overview of the high-level cost drivers in the premium change compared to 2021. In 2020, COVID-19 introduced significant uncertainty regarding healthcare costs and rate development. Both CalPERS HMO and PPO plans followed similar patterns for the monthly COVID-related costs, including testing and treatment. COVID-19 cases and their associated costs began in mid-March and peaked toward the end of July. Costs decreased until around October, at which point we saw a second surge in COVID-related costs throughout winter 2020. There was not as much fee-for-service savings in 2020 as we expected during the 2021 rate development process. For many plans, part of the savings realized on medical claims was neutralized by the unexpectedly high pharmacy costs. Most of the health plans expect that services will return to normal levels at some point in 2021. About 70% of eligible Californians and eligibles over the age of 12 have received at least one dose of the COVID-19 vaccine. The vaccine itself is covered by the federal government, and the administration costs are covered by health plans. It is possible that the deferred care in the first half of 2021 will offset vaccine and other COVID-related costs. No significant COVID-related healthcare costs are expected in 2022. A booster shot may be released sometime in the fall of 21 or 2022 to supplement the vaccine, but these costs should be immaterial. However, we do anticipate additional utilization from delayed and deferred care into 2022. Now, regarding pharmacy, utilization and trend came in significantly higher than what was projected for the 2021 plan year for a couple of reasons that Dr. Moltz discussed in his opening remarks. Most notably, utilization for the 2021 plan year is showing that we underprojected pharmacy costs for this year. Further, under the new acquisition-based contract, when Optum filed its rate proposal for the 2022 plan year, it did not accurately account for all of the appropriate contract provisions. As a result, the team had to use its external pharmacy actuarial consultant to build the rate consistent with these contractual requirements. We are working with Optum to address its submission, and although we don't anticipate the overall pharmacy rate to change significantly between June and July, we do anticipate some adjustment in individual plan pharmacy rates when we present final premiums in July. So the chart to the right shows the cost drivers for the overall 2022 premiums compared to 2021. In addition to the pharmacy increase, 2.8% accounted for medical inflation, 2.16 came in from the snapback from the 2021 healthcare fund premium buy-down adjustments. This adds up to a total of 6.21% increase before the recommended healthcare fund premium buy-down adjustment for 2022. The premium change would be 4.92% with healthcare fund adjustments. Next slide, please. With the recommended healthcare fund adjustments, the overall premium increase is 4.83%. The overall premium PPO premium increase is 8.31%. Comparing this to the Mercer Oliver Wyman trend benchmark from the January 2021 healthcare report, for the preliminary premiums, the HMO portfolio came in significantly lower than the national benchmark. The overall program increase of 4.92% also significantly beat the national benchmark. However, the PPO portfolio came in higher than the national benchmarks. The reason the PPO came in higher is driven by a few issues. One, the high-cost areas of California that are only served by the PPO. Two, the fee-for-service medical trend. And three, the pharmacy issues we just covered. I'll discuss in more detail the cost drivers in the PPO when we discuss those plans individually. Next slide, please. I'm going to walk through each plan and discuss each element of its proposed premium, starting with the HMO plans. The 2022 basic HMO premiums are portfolio rated using the MARA prospective risk scoring tool with a 2-year phase-in. The risk neutral premium for a health plan is set by taking the average risk score for the members enrolled in that plan and removing that risk from the plan's medical and pharmacy costs. As a reminder, a risk score is a measure of how costly an individual's medical needs are compared to the average population. A CalPERS member with a risk score of 1.00 means that person's medical costs are at the level of an average person in the CalPERS basic program. Similarly, a risk score lower or higher than 1 means that the person's medical costs are lower or higher than the average. The risk scores are adjusted to account for volatility for plans with a small enrollment size. A credibility adjustment is applied to plan level risk scores for those plans with enrollment of less than 25,000 members. HMO plans subject to the adjustment are Anthem Traditional, Blue Shield Trio, HealthNet Saluti Mas, HealthNet Smart Care, Sharp, and Western Health Advantage. Next slide, please. Let's start with Anthem Traditional. It's a broad network HMO and is offered in many of the high-cost, low-competition areas of the state. On this slide, the first table on the top shows the 2021 premium, the preliminary proposed premium for 2022 before portfolio rating or the recommended healthcare fund buy-down adjustments, the change in dollars and percentage, as well as the total covered lives currently in the plan. Before portfolio rating, the 2022 premium increase for Anthem Traditional was 13.19%. To the right of this table, we have a chart that shows the cost drivers that led to the 2022 premium. Most of the premium increase came from a snapback from the 2021 premium buy-down of 8.78%. The middle table shows the risk score and the portfolio rating impact for the plan. Anthem Traditional has an average risk score of 1.2524. This indicates that the plan has sicker than average members in the basic portfolio. In fact, Anthem Traditional is one of the plans with the higher risk scores in the portfolio. With the credibility adjustment and 2-year phase-in, the risk score used in the 2022 premium is 1.0880. Portfolio rating brought the premium down by 8.07% to a 5.12% increase. The bottom table shows the team's recommendation to use surplus in the plan's healthcare fund subaccount to buy down premiums. For Anthem Traditional, the projected surplus is approximately $12.4 million as of December 2020. We recommend using 80% of the surplus to offset some of the premium impact to our members. This results in a 1.26% premium decrease for 2022. Next slide, please. Anthem Select is a narrow network plan with a strong presence in the Bay Area and Central Valley. Anthem Select has a projected premium increase of 7.71%. Higher than expected pharmacy costs have contributed to the overall premium increase by 2.84%, compared to approximately 1% of normal pharmacy trend. The plan has lower than average risk score, so portfolio rating has brought the premium up by an additional 2.53% for a total of 10.24% increase over 2021. The projected healthcare fund surplus for this plan is approximately $13.1 million as of December 2020. Applying the same principle of using 80% of the surplus to buy down the increase, we recommend reducing the premium increase to 7.72%. Next slide, please. Blue Shield Access Plus is a broad network HMO with populations concentrated in Sacramento and Los Angeles counties. For 2022, Blue Shield Access Plus is re-entering 8 of the 9 Bay Area counties they exited in 2019, all of those except Napa County. Blue Shield projected a modest premium change for 2022. Most of it is due to a snapback from the 2021 premium buy-down. Portfolio rating has reduced the premium by 12.5%, leading to a decrease of 3.92%. We don't recommend using healthcare fund surplus to bring the premium down further. We'd like to be conservative with the use of healthcare fund surplus dollars to ensure availability of the fund to help mitigate any future premium volatility in this product. Next slide, please. Blue Shield introduced Trio in 2020. The board approved Trio's expansion of their service area into Orange, Santa Cruz, and Stanislaus counties for 2022. Blue Shield is not moving forward with the Monterey County expansion due to challenges with provider contract negotiations. Trio had a 0.94% portfolio rating impact to their premium, leading to a 5.15% change in premium. We recommend using 80% of the healthcare fund surplus to reduce the premium increase from 5.15% to 3.84%. CalPERS will be adopting changes to the Trio formulary that are designed to address low-value prescriptions. These changes are consistent with formulary changes previously made in the OptumRx formulary, and the net impact will be a 2% decrease on net pharmacy costs, which will translate to a 0.3% decrease in statewide premiums for Trio. This change will be included in the final proposed premiums in July. Next slide, please. HealthNet Salud-y-Mas is a plan with a very narrow network that provides services to a small population in the lowest cost counties in California: Kern, Los Angeles, Orange, Riverside, San Bernardino, and San Diego counties. The projected premium before portfolio rating increased 9.09%, mainly driven by the underprojection of the 2021 medical costs due to COVID and the higher than expected pharmacy rate for 2022. In fact, Salud-y-Mas had the highest COVID-related costs on a per member basis among all CalPERS basic plans in 2020. Salud-y-Mas has a risk score of 0.6953, meaning the plan's members on average are about 30% healthier than the CalPERS average. With the credibility adjustment and 2-year phase-in, Salud-y-Mas received a 12.55% portfolio rating impact to the premium, which led to the overall increase of 21.64%. We recommend using 80% of the healthcare fund surplus to reduce the premium increase from 21.64% to 13.28%. Even with the premium increase in 2022, Salud-y-Mas has by far the lowest HMO premium for the basic portfolio and is 20% lower than the 80/80 state contribution of $607 for 2021. Next slide, please. HealthNet SmartCare is a standard network HMO operating in 20 counties. This plan has experienced volatile member migration patterns and risk concentration fluctuations in the past few years. For 2022, SmartCare had a 9.01% premium increase after the downward impact of portfolio rating. The main cost drivers are the higher than normal medical and pharmacy trends and the 2.63% snapback from the 2021 premium buy down. The healthcare fund subaccount for SmartCare is in a small deficit as of December 2020. Therefore, there is no premium buy-down opportunity for SmartCare. Next slide, please. Kaiser is a closed network, fully insured HMO plan that carries all financial risk for services provided. It operates in 31 counties throughout the state. Kaiser proposed a premium increase of 2.68% for 2022. This is very modest and one of the lowest in the basic portfolio. Even though it is a very competitive rate, we are continue to analyze Kaiser's financial position to ensure that our members are getting the best deal we can negotiate. Portfolio rating has brought the premium up by additional 2.97%, leading to an overall premium increase of 5.65%. Because Kaiser is a fully insured plan, there is no opportunity to accrue a healthcare fund balance. Next slide, please. Sharp is a closed, capitated provider network HMO that provides services to the San Diego area. The 2022 preliminary premium increase is 5.01%. Sharp has a 6.43% portfolio rating impact due to their lower risk concentration. The premium increases 11.44% overall. Keep in mind that Sharp is one of the lowest cost plans within the portfolio, so even with this increase, it is still more than $100 below Kaiser. The healthcare fund account for Sharp is in a deficit as of December 2020. This is carried forward from the losses accumulated from the previous 5-year contract. We anticipate the healthcare fund deficit will recover slowly due to the flex funded arrangement. Therefore, there is no premium buy down opportunity for Sharp for 2022. Next slide, please. United Healthcare Alliance is a standard network HMO plan operating in 26 counties. The 2022 preliminary premium increase without healthcare fund adjustment or portfolio rating is 9.73%. Alliance main cost drivers are medical costs, pharmacy costs, and 2021 snapback. Alliance has a 1.28% portfolio rating impact to their premium for an overall 11.01% increase in premium. The team recommends using 80% of Alliance's healthcare fund surplus to reduce the premium increase to 8.09%. Next slide, please. United Healthcare Signature Value Harmony is a new basic HMO plan for 2022. Harmony is a narrow network plan in 5 Southern California counties: Los Angeles, Orange, Riverside, San Bernardino, and San Diego. The preliminary portfolio rated premium for 2022 is $737.67 with a risk mitigation impact of 7.86%. This is based on the projected risk level from the Bates-White economic model. The bar graph on the slide shows the HMO basic plan state premium. Harmony's preliminary premium came in the 3rd lowest, mainly due to being in the lowest cost counties in Southern California. Harmony has a highly capitated model, which is expected to be more efficient and cost effective. Next slide, please. Western Health Advantage has a fully capitated provider model that services the Sacramento area. For 2022, Western Health Advantage will expand their basic HMO plan into Humboldt County. This plan is also interested in expanding its Medicare Advantage product into Humboldt in 2023 if it receives federal approval. Western Health Advantage's service area expansion will create the first low-cost HMO available in Humboldt County and is great for our members. Western Health Advantage has a negative 2.21% portfolio rating impact in premium for an overall 1.93% increase in premium. We recommend using 80% of the healthcare fund surplus to reduce the 1.9% premium increase to a 1.51% decrease. Next slide, please. Before we jumped into the Medicare plans, I wanted to show the preliminary premium levels for each of the basic plans together as a portfolio. As you can see, there is still variation in price points as we transition towards portfolio rating. Next slide, please. Anthem Medicare Preferred will expand their service area into an additional 21 counties, making it a statewide plan for 2022. Anthem is offering new benefits enhancements, a healthy pantry program, which offers nutritional counseling sessions and non-emergency transportation. In addition to the service area expansion and supplemental benefits we shared in November, Anthem is also offering to reduce the member out-of-pocket costs from 10% coinsurance and to $0 copay for durable medical equipment, continuous glucose monitors, diabetic supplies, including preferred brand blood glucose monitors, and diabetic therapeutic shoes and inserts with no additional increase to the premium. Anthem Medicare Preferred has a modest premium increase of 1.75% for 2022. I'll mention again here, Medicare plans are not included in portfolio rating as the Medicare program is already risk adjusted. The team recommends using 50% of the plan's healthcare fund surplus dollars to reduce the preliminary proposed premium to $357.70 for a 6.7% decrease from 2021. We would like to take a slightly conservative approach with using 50% of the healthcare fund reserve because this is a relatively new plan that started in 2018 and enrollment has grown slowly ever since. We'd like to be conservative with the use of the healthcare fund surplus dollars to ensure availability of funds in future years to mitigate any volatility in this plan's premium. Next slide, please. For Kaiser Senior Advantage, there are no benefit design or service area changes for 2022. The 2022 preliminary premium is $302.53. This is a 6.76% decrease from 2021. This is primarily driven due to an increase in CMS revenue. Next slide, please. Sharp Direct Advantage Medicare was introduced in 2021. As I mentioned earlier, for 2022, Sharp Direct Advantage will have $0 copays for several services, and the ER visit copay will remain unchanged at $50 per visit. Also, I want to note here, this plan has 68 members enrolled, which is why we are seeing an increase. As more members enroll, the premium will stabilize. However, the 2022 preliminary premium of $263.85 is the lowest premium in the CalPERS Medicare program. Next slide, please. There are no benefit design or service area changes for the United Healthcare Group Medicare Advantage. The 2022 preliminary premium is $294.65. This is a 5.43% decrease from 2021, mainly due to an increase in projected revenue from CMS. Next slide, please. The table on this slide shows the preliminary premiums for the new Medicare Advantage plans for 2022, Blue Shield Medicare PPO, United Healthcare Edge, and Western Health Advantage Medicare Advantage. I'm pleased to share news that Blue Shield Medicare Advantage plans approved by the board in November will be available nationwide, not just statewide. This gives our retirees living out of state more choice to access care no matter where they live in the country. This nationwide expansion had no increase nor impact to the premium. The preliminary proposed premiums are displayed on the bar graph alongside the current Medicare Advantage plans we offer. Next slide, please. This is a little repetitive, but here you can see all of the preliminary premiums for the Medicare Advantage plans for the 2022 plan year. Next slide, please. Moving on to the PPO plans. As you may recall from our discussions of portfolio rating, the PPO, it's performed a little bit differently than the HMO. Unlike the HMO plans with different carriers, the PPO plans are all administered by Anthem. They fall under the same business model, the same care management approaches, the same underlying provider contracting, and the same geographic footprint, which is the whole state. This allows us to price the PERS Platinum and PERS Gold plans based on the value of the networks and the benefit differentials. I already discussed the general cost drivers across the portfolio, so I'm going to spend a little bit more time here on why the PPO is experiencing higher premium increases than the HMO. Without the requirements of choosing a primary care physician for specialist referrals, PPOs have relatively loose care management compared to HMOs. This results in higher utilization in services like outpatient, professional specialist, ambulatory surgery, and pharmacy, regardless of population risk. PPO utilizations of these services are more than 40% higher than the HMO. The capitation payment system used with the HMO creates a more cost-efficient healthcare system compared to the PPO fee-for-service payment system. This results in lower unit costs for some services, such as inpatient, emergency room, and physician services in the HMO. PPO plans cover out-of-network care that the HMO plans do not. Out-of-network service cost is much higher than in-network, as there is no provider contract and no care management for out-of-network services. The unit cost for out-of-network inpatient hospital is more than 25% higher than in-network inpatient hospitals. And finally, based on 2019 experience, the overall healthcare costs for the basic PPO members were roughly 18% higher than the basic HMO average. Next slide, please. As approved last November, the 3 PPO basic plans will be replaced with 2 PPO basic plans in 2022, PERS Platinum and PERS Gold. PERS Platinum has the same network and benefit designs to the current PERS Care plan, and PERS Gold has the same network and benefit design to the current PERS Select plan. You can see from the left top table, the PERS Platinum will have a 12.01% decrease from the 2021 PERS Care premium and about a 15% increase from the 2021 PERS Choice premium. This also accounts for the increase in benefits from the PERS Choice 80/20 plan to the PERS Platinum 90/10 design. The 2022 PERS Gold premium is about 22.92% higher than the 2021 PERS Select premium. The bar chart on the right shows the detailed breakdown of the cost drivers. The under projection from the 2021 premium is carried forward. The higher than expected pharmacy costs contribute an additional 2.8% to the premium increase. Combining these with the medical trend and the snapback from the 2021 premium buy down, we have a total increase of 10.96% for the overall PPO basic program. As a reminder, the PPO Healthcare Fund Reserve policy states that premium adjustments may be considered when the fund to balanced actuarial reserve ratio falls below 90% or exceeds 110%. As of December 2020, the combined ratio for PERS Choice and PERS Care is at 113%. We recommend using 80% of the healthcare fund surplus to buy down the 2022 PERS Platinum premium to bring the ratio down to 103%, a much more prudent threshold. The healthcare fund account for PERS Select is in a deficit as of December 2020. The fund balance to actuarial reserves ratio falls below 90%. We don't recommend implementing a surcharge for 2022. With the recommended premium buy down adjustment, the overall basic PPO premium increase will be reduced from 10.96% to 8.31%. As a reminder, the PERS Platinum premium with healthcare fund adjustment is about $29 or 3% lower compared to what we presented in November when the risk mitigation strategy was approved. PERS Gold premium is about $4 or 0.6% lower. Next slide, please. Just like the basic plan, the current 3 PPO Medicare supplement plans will be replaced with 2, PERS Platinum and PERS Gold Medicare Supplement. These plans will have the same provider network throughout all 58 counties. PERS Platinum will also be available for out-of-state members, while PERS Gold is exclusively for in-state members. The benefits offered under PERS Platinum will be identical to the current PERS Care and nearly identical to the PERS Gold. PERS Platinum will only have slightly richer coverage over PERS Gold for hearing aids and other benefits that are beyond traditional Medicare coverage. For 2022, PERS Platinum Medicare will increase about 6.22% from the 2021 PERS Care Medicare premium and about 15.71% from the 2021 PERS Choice Medicare premium. The 2022 PERS Gold premium is about 9.66% higher than the 2021 PERS Select premium. Overall, we see a total increase of about 10.07% in the PPO Medicare supplemental plans, mainly driven by an 8.81% snapback from the 2021 premium buy down. We recommend using 80% of the healthcare fund surplus to reduce the premium increase from 10.07% to 6.16%. Next slide, please. Here we show you the 2022 preliminary premiums for the total basic plan portfolio. You see here that monthly premiums range from $1,205 to $482. Next slide, please. And here are the 2022 preliminary premiums from the Medicare Advantage and Medicare Supplement plans, ranging from $386 to $264. Next slide, please. For next steps, the CalPERS team will evaluate the plan's updated data, trends, and assumptions, and will continue negotiations. We will present final premiums in July for board approval. The 2022 health premiums will be effective on January 1st, 2022. That concludes my presentation, and I'm happy to take any questions.
Thank you, Ms. Green. Thank you for a very concise presentation. Appreciate that. I also want to thank you and your entire team for all the work up to this point. I know that they took a lot of it on under your direction without you while you were gone for a while. So I thank all of them for putting their best foot forward. I do want to say that the plans have heard me say in the past that I want you to come with sharper pencils. I'm not going to say that this year. What I'm going to say is, first of all, I'm going to say thank you to Western Health Advantage for the expansion into Humboldt. I think that gives our members a good opportunity up there. Also, I want to say thank you to the plans that have partnered with our staff so far this year. But I'm also going to say that there appear to be a few that have not chosen to partner with our staff this year. And I encourage you to do so, to not only just partner with our staff, but partner on the other side with your hospitals and your provider networks out there, so you can come back with a better rate for us. Our members have hurt this last year, and it's going to continue. We need to get to the best rate possible, and I need you to understand that this committee has options, and they may or may not have chose to offer those in the past, but there are options on the table for us. So come to in July with your best numbers. Those that don't, I will probably call you out personally. I want to see this action take place. So with that, I have a number of board members that wish to speak, and then we have quite a number of the public that wish to speak. First, I have Mr. Rubalcaba.
Thank you, Mr. Fechner. First, I do want to concur with your statements, and thank you for saying that for the general public and the carriers to hear. I do want to thank Ms. Green and her team. It was an excellent presentation. I do have a question. All these rates is it because of a human risk mitigation approach, the portfolio rating, and a lot of that depends on adjusting the rates so it's based on the value, not so much the risk. And so a clear point of that is calculating the risk factor, which is very key. And so it has interesting results on every plan. And sometimes a percentage increase or decrease is interesting and can be taken out of context. But I do want to thank you and commend you for doing this approach. I think this is the best way for people to see the value of benefit. And it also diminishes the opportunity for trying to grab market just through having a plan design or a rate that would attract the best risk, I would say, the young invincibles, they used to call them. But I do have a question. It is a 2-year, I have a couple of questions. It's a 2-year transition. So one of the things that's going to have, and we're going to hopefully see it, we started seeing it for example, Anthem Traditional and for Blue Cross Access Plus, is there'll be less volatility, there'll be less snapback. So do we expect that trend to continue second year, or it will be less subdued in the adjustments that would have to be done? That's the first question.
What you'll see is a reduction in the member migration patterns and a reduction in the concentration of risk. And so that will be a smoothing in the premium adjustments year over year. So those that were completely flat and that were underpriced relative to their risk, those you'll start to see to moderate and increase to the nominal price of healthcare. And those that were skyrocketing because they were experiencing volatility due to adverse selection, those will moderate. So will either level off or will decrease. Then you'll also see the enrollment shifts that were happening. So people fleeing the high cost plans, which was sending them into a death spiral, that will moderate as well. And then once everything's priced risk neutrally, all of those patterns stabilize. Thank you.
You say so much better than me. I had the note there to use the word smoothing, but I forgot. But because that's something in actuarial, you smooth the impact, not here, but 37 not counties. The other question is related to that, to some of the answer you gave. We have a couple narrow networks, quality providers, the best way to say it. And because they tend to be fully capitated, mostly capitated or owned by the provider, by the carrier. And so that helps provide a higher quality care management. We have the introduction of one, Harmon, new one. And I know, my question is, how did you get to the risk score? Because I noticed, for example, the other one, Trio, has closer to average on the risk score. So I'm just curious how we got to that number.
So we use the Bates-White economic model, which has a sophisticated member migration pattern that actually looks at all of our members and all of their risk scores and where they will move as a result of the introduction of new products. So that's how we brought forth our recommendation of the approval of Harmony, and it's how we mapped out their likely risk score.
Thank you. That makes sense. And my final question is regarding Kaiser. It's a fully insured plan, so there's less adjustments the CalPERS has to do. But on the other hand, they assume the risk, I guess. So that I guess it balances out. So how would you think going forward we will see will the same pattern happen to that plan as the other plans, where we see smoothing out of the rate, less up and down, less volatility?
Yes and no. I mean, Kaiser's risk score hovers right around 1.0. I mean, it's very close. It's slightly below 1 currently, but it is really close to 1. And some of that's because it is just so large within the portfolio. So something that is that big ends up kind of defining the middle of the portfolio just because it's so large. It ends up becoming kind of the average. And so Kaiser hasn't in our portfolio, if you look at it over time, it has never seen those 10 and 15% and sometimes 20% increases that we saw like at the end of risk adjustment when you started seeing massive changes in the portfolio. So it just has never seen the level of volatility that some of our other products have seen. But in general, yes, you will see kind of a leveling off of all of the products. But again, that the volatility that has been in some of the other products has never actually existed in the Kaiser product.
Thank you very much. And again, thank you for the great work you did. And I want to commend you and the whole team for this new approach. It's on how to deal with risk mitigation. So thank you.
Thank you.
Thank you, Mr. Fickner.
Thank you, Mr. Chair. And I do want to also thank the team for all the hard work that they've done. And I sort of want to repeat what Mr. Fickner said, which is we had some very cooperative partners in this, and we had some that were not. And I'm asking them to come back to the table and work a little harder. But I would also ask, and I think I've mentioned this before in open session, I think our carriers need to be working harder with the providers and networks to come up with better rates as well, because I know that they're passing on rates to us that come from the hospital and doctor networks, et cetera. And I think that we really need to ask them to sit down with those providers, hammer out better deals, and then come to us with better deals, because a lot of I represent all state employees. I represent all CalPERS, but state employees took a 10% pay cut, and now we're asking for state employees to take a huge amount of their paycheck for healthcare, and this is becoming unsustainable for our employees. And I think I speak for all of the employees, whether they're my employees or our local agencies or even our retirees. These are unsustainable rate increases. And there's a couple of questions I had. I know that the risk adjusting or smoothing is going to help us kind of stabilize everything. But as we buy down the rates every year, we cause a snapback. So as we're buying down this year, my first question is, what kind of impact is that going to have for next year?
So you will see some level of snapback from buy downs. It's part of the cycle that we want to get out of with the long-term portfolio rating strategy. With having the lack of stability in portfolio, this is why we had the expansion and contraction, or one of the reasons we had the expansion and contraction in the healthcare fund sub-accounts that we were seeing over time. And so by creating these smooth and predictable rates, that for our members, we will also see more smooth and predictable healthcare fund subaccounts. And so we will see much more modest adjustments with the healthcare subaccounts buy downs, and then therefore snapbacks associated with those to be very, very small and absorbable. But you will see some associated with these buy downs. Though many of these buy downs are more modest than we have seen in recent years, though still a prudent thing to do to reduce the impact of rate increases for our members. But over time, this is what we want to get away from.
I agree. I appreciate that. Yeah, I thought that might have an impact. And again, I just want to reiterate, it is getting just imperative for us to find out any way we can to work with our carriers to bring these costs down. But in addition, I'm wondering if you could kind of go into, and I know we covered this before, but I'm getting questions. So I'm wondering if you could go into some of our mitigation tactics that we've been trying to help costs lower or maintain costs so they're not quite as high. If you could go into a few of the things that we've done this year and even before.
Yeah, so some of the tactics that we're really focused on right now is bringing lower cost, higher value products into areas that don't have access to those products. And so one of the things that I'm really excited about is bringing those new products like the expansion of Western Health Advantage into Humboldt, the expansion of Trio. We're really encouraging our carriers with those high value networks, those networks that have those providers that are efficient and effective at treating members at those lower price points into areas so members have choice. Some members may choose to remain with high cost providers, and we want members to have that choice. But at the same time, we want members to be able to choose more efficient and effective networks at that lower price point. So really being able to bring effective, efficient networks to our members, no matter where they live in the state, is kind of our number one priority. And then also getting a handle on these pharmaceutical costs, as we've talked about from the beginning of the presentation with Dr. Molt's opening remarks, and doing a better, effective job in working with our PBM on those costs. Those are the two I'd like to point to. Dr. Moltz, do you want to add anything?
Those are the two that are top of my list for sure. The other one is the broader competition study, which is to create more competition in low competition or monopolistic areas. We were successful doing that in Santa Barbara last year. We came very close to being able to do that in Monterey with Trio this year, but ultimately the negotiated price was gonna result in an increase in overall state costs that we didn't want to subject members to. We'll make another run at it. Shield, we're talking to other plans about moving into areas with innovative options that do everything from trying to divert traffic from monopolistic hospitals into lower cost of care settings, to just creating competition. Those are all longer term strategies. Short term, and I'll just reiterate what Marta said, we want to get HMOs into these areas where right now the PPO is the only option. It is, PPOs are more expensive because for many reasons, including the fact that there's no managing of care. And if people want to pay more for a product like that, it's one thing, but when it is their only option, that's a problem. So, we've already started talking to a number of our plans about moving into some of these areas where the PPO is the only option to create a second option for 2023. And we'll continue those conversations right up until we're doing rates next year.
I appreciate that. I wondered, and I think you guys may have answered this question before, could the state be a partner in driving somehow or another doctors to those areas through an education stipend of some kind?
Yeah, some of there are programs that exist to do that. Agency provides a heavy deferment of medical school debt for doctors who go into practice in in rural areas and underserved areas. A lot of those folks leave. Some of those folks stay. The other option is being creative about how you string together a network. We are doing, as I think we've talked about in other meetings, we're engaged in this study right now to look at our telehealth experience, because we think for certain kinds of healthcare, telehealth is a viable option. It gives a second option for some people. It brings providers where there are no providers. It's particularly effective at increasing participation in behavioral health services. Those kinds of technological developments may allow us to put together networks in areas where we have not had networks in the past. Being more creative about the entities outside of hospitals that we contract with is another possibility. We've been looking at and will continue to look at the possibility of moving people out of high cost areas on a voluntary basis for schedulable surgery. So there's some tools in the toolkit. We are talking to the carriers that are doing this work in these high cost counties about using those tools, and we'll continue to do that. We've been talking to Cover California and DHCS about the same thing. They face a number of these challenges in areas where there's minimal provider coverage also. And I've said that I'm meeting with Dr. Logan, with Peter Lee and Will Lightbourne from Cover California and DHCS every other week now. This is one of the things that is on the agenda. Behavioral health improvement, another thing on the agenda. But we ultimately, the best way of making California is for the three of us to team up and send a collective message.
Well, again, I want to thank you and the team and Marta for all of this hard work. So reiterating that I know you're not the only ones at the bargaining table, and it makes it difficult when you're up against a brick wall. So I reiterate that by July, I'm hoping that our carriers come to the table with better rates for our members, and it's imperative. These rates are just unsustainable. Thank you.
Thank you. Mr. Miller.
Yeah, thank you. Thank you, Dr. Molds and Ms. Green, for the presentation. The fine work of the team. I have to say that it's challenging material. It's complex. It can be confusing, but your presentation has been comprehensive, concise. It's comprehensible. A great job bringing this to us in a way that we can really understand it and go forward. And I encourage you to keep the heat on in the negotiations. As my colleagues have said, we still hope to see improvements for July. And most importantly, all the work you're doing and the leadership in terms of getting to some of the root causes, not just the negotiations over what has happened and what is the current state, but getting to the root causes of the cost drivers of healthcare service and delivery, and ability to have improvements on accessibility and quality, and particularly the pharmaceutical emphasis. I've talked before about my long-term vision of a world without PBMs, but we're a long way from that. And so we've got to really continue to make progress where we can. And so, again, great job for the team. I had a question, kind of two questions. You had mentioned, Ms. Green, that we're not expecting to see the kind of COVID impact in terms of the dollars, but we've still got tens of millions of people who are not vaccinated, and many of whom do not intend to be vaccinated, even within the healthcare industry. And it seems like that would be a factor that would generate ongoing concern and costs. And also, last year, we basically had almost no flu season because of all the mitigation and all the precautions we took because of COVID. And with the mask mandates and social distancing and everything being somewhat reduced, and with, again, a lot of people non-compliant even when they were in, do you see that as something that the jury is out, whether we'll have costs next year as that all comes into play again?
Thank you, Mr. Miller. It's always an inexact science predicting the future. However, we do rely on a lot of the work of the various academic institutions that are looking at that kind of prediction of what's going to happen with the virus. So we look at what the University of Washington is looking at. We look at what the Johns Hopkins University is looking at. We actually have our own in-house epidemiologist that's helping us think through what the viral patterns are likely to do, and then the subsequent healthcare costs. And so even if we do see hotspots relative to low vaccination rates in each county, which I can talk at great length about vaccination rates given my temporary assignment this year, we just don't see it rising to the level that we saw over the winter. And even then, the COVID-related costs that we saw last winter when we had no vaccine for the CalPERS book of business was relatively low. So now that we have a high percentage of the eligible Californians already vaccinated, even with vaccine breakthrough, at least from a fund perspective, we're relatively well protected. We certainly, from a healthcare perspective, from the health of our membership perspective, we still want our members to take all of the important precautions and distance and mask and do all the things that they should be doing appropriately and get the vaccine if they haven't already been vaccinated. But from a fund perspective, based on kind of what we think the virus is going to do, it does not look like we're going to experience significant healthcare costs as a result of COVID.
Yeah, and you kind of touched on my next question already a little bit in terms of, the non-vaccinated, kind of the non-compliance factor there isn't really, it doesn't seem to really be evenly distributed throughout the state. It seems like there are areas with much higher levels of unvaccinated people, and it seems like something that could have a differential effect depending on what plan you're in and what part of the state you're in.
There are certainly regional differences, which, there's great data on the California Department of Public Health website on the regional differences in vaccination rates. There's also differences in vaccination rates by socioeconomic class and even by zip code, right? There's just so much interesting data about variation in vaccination rates. So yes, as we move forward in the pandemic, if we are to see outbreaks, there's likely going to be differences in where they occur. But again, as we look at it as a whole portfolio and as a whole fund, kind of in the global way, it still is not going to rise to the level to where it's going to be of a major cost driver or major cost factor for us as a fund.
Yeah. And then my final question. Next year is probably too soon to be thinking about, but how is the medical community thinking about the kind of longer term implications of COVID? Because there seem to be indications that there a lot of patients are having or may have longer term complications that aren't really as apparent right away in terms of a long-term implication for costs associated with people who've been infected and have come down with it.
Yeah, I think that's a really interesting question. I think there's a lot of unanswered questions about what the long-term impacts are. I always think about kind of what our colleagues in Europe think about as a bellwether, because many of those health systems are nationalized, so the governments have to think about it as kind of their long-term budgets. And many of them are thinking about it in the context of healthcare over the long term. Like what is it going to mean for long-term kidney disease, and what is it going to mean for long-term healthcare issues? And so there's just a lot we don't know, and it's something that we'll continue to monitor over time. But it'll be very, very interesting. Dr. Molds, do you want to add anything there?
I was just going to add, because I'm not the right kind of doctor to really be answering this question, that Dr. Logan has been tracking this very closely and will be a good subject for her to spend a little bit of time on when she gives a COVID update. Our COVID updates will migrate to different kinds of updates, hopefully at some point. But this is, this is one I know that she's been watching carefully. It's an evolving area. The question about long-term COVID and what it means for people who have symptoms after they had COVID is going to be something that we're going to want to watch. And I know something that she's been tracking. So we'll have her say a little bit more at an upcoming board meeting.
Great. Well, thank you all, and thanks to the entire team. Great work.
Thank you, Mr. Jones.
Thank you, Mr. Chair, Ms. Green and staff. I just want to echo my colleagues and thank you for taking such a large amount of complex data and present it in an easy to follow format. So it really is, applaud you for that. Also, I want to thank you for your continued and staff's continued effort to negotiate with our carriers, where I believe, and I'm sure that others support that we are trending in the right direction, but there's still work to be done. So I know you guys are working hard to get those rates to more reasonable levels. I also want to applaud you on recognizing that, looking at the information, that there's some new enhancements that you've negotiated in some of these packages that such as nutritional counseling and non-emergency medical transportation and post-discharge meals, which are all beneficial to our members. So thank you for negotiating those. And also thank you for the almost on-time updates to our stakeholders. I mean, I think you crossed the Rubicon, as they said, that they're getting this information almost at the same time as we're getting it. So I know they're very pleased with being kept up to date on getting this information in a very timely manner. And I do have a question. I looked at some of the data. I was looking at Kaiser, for example, and I looked at, compared to HMO, I looked at in-state versus out-of-state, and the out-of-state rates were higher than the in-states for the HMO. Then I looked at the category that older members in Medicare, like myself, it's just the opposite, where the rates for the out-of-state was less than the Senior Advantage program in state. So why is this different?
It's a really good question. So for the basic, on the basic side, for Kaiser, a lot of times in various parts of the country, they rely on a blend between kind of what you're used to in California, which is they're fully integrated, and then some contracted access. And so you can end up with a little bit higher costs in the basic program. And so that's why you can see the out-of-state basic ends up being a little bit higher cost than the in-state basic, because in California, it's a really well-established program and integrated. And in not all places in the country, the out-of-state is as integrated as it is in California. So that's the difference there. On the Medicare side, I would have to look a little bit more into it, but I suspect the opposite is true, because in the Medicare program, as you know, the reimbursement rate is the Medicare reimbursement rate. And so you don't have those distinctions of the fully integrated versus the not integrated, because if you take the Medicare rate, you take the Medicare rate. And so I suspect it has less to do with the nature of Kaiser's model and more to do with just some other states, maybe just slightly cheaper. But I can look into the Medicare differential, but I'm pretty confident in the basic differential.
Okay, thank you for that explanation. Thank you. Thank you, Mr. Chair.
Thank you. Ms. Olivares.
Thank you, Mr. Chair. I want to thank the team for doing such a great job. It's very thorough coverage of premiums. I think I had a similar question last year, and this is going to be about quarterly profits. So despite COVID, we've seen a marked increase in quarterly profits. Kaiser posted $2 billion in quarterly profit for Q1 2021. Anthem posted a $1.7 billion surplus for the Q1 2021. United Health Group had a $4.9 billion profit for Q1 2021. And so as I look at, there's a website, Kaiser Family Foundation, and you can look at loss rates, and you can see that average medical loss rates are actually down. Profits are up. Average gross margins per member are up. So as we see premiums rise, there is a very strong correlation with health insurers' profits rising. I want to make sure that our members are not paying for these profit increases, that they're truly costs that must be borne. How do we discern that?
So that's why we flex fund, honestly. So why we've constructed the program the way in which we've constructed it. So what we pay the carriers on a per member per month basis for their administrative fees, which includes profits, right? It's what the fees to operate, including their profit, is static over the term of the contract. And then the carriers act as a pass-through for capitation. I'm going to set Kaiser aside for just a minute. We'll talk about Kaiser separately, but everybody but Kaiser. So you've got the set per member per month payment, which is your administrative services fee. Then the carriers act as a pass-through for the capitated payments directly to the providers, so whatever their capitated arrangements are. And then CalPERS pays the fee-for-service claims directly. So that's why when we set the 2021 rates, we predicted a little bit more fee-for-service savings. So CalPERS retained those profits or predicted those profits for the 2021 plan year. Now we predicted a little bit high. We thought we would have more profit in our healthcare fund accounts than we are seeing in claims. More claims are coming in because we pay those fee-for-service claims directly. But what we pay the carriers on an administrative services fee in our flex funded arrangements doesn't change. So they, again, setting Kaiser aside, they cannot profit any more off of CalPERS book of business than whatever they negotiate in the 5-year contracts at the beginning of the flex funded term. Because again, they're just a pass through for the capitated payment arrangements, and we're paying the fee for service amounts directly. Kaiser, one of the things you'll notice is that what we're seeing with them is this one of the lowest increases in the entire book of business. And we have been working very closely with Kaiser to look at not only its total financial position, our total financial position within their book of business, but also the utilization of our membership and our own claims data, which is why we gather all of the claims and encounter data to understand how much we are using, how much of healthcare we are using relative to their book of business or their total, so that we know that we're getting a really good deal or a very good deal from Kaiser. So on the flex funded side, they actually can't increase profits because it's negotiated at the beginning of the 5-year term. And on Kaiser, because it's fully insured, we have to take a slightly different tact and actually dig into their finances and dig into specifically the finances relative to our membership and our utilization. So that's kind of the two ways in which we're really monitoring the spend on behalf of our membership.
And when setting up the administrative fee, and I know that does include a bit of profit, how are we determining what's a reasonable amount of profit?
Well, we don't delineate profit within the administrative services fee. So we look at the fee itself on a per member per month basis, and we just aggressively negotiate that fee. And we pit the carriers essentially against each other to ensure that we get the lowest administrative services fee that we can get from our carriers. Because we really want to ensure that it's the leanest product design as possible. So we don't say that of the per member per month that 50 cents is profit, but what we say is that you're going to come in as low as humanly possible.
So if profits are rising across all the carriers at almost unforeseen levels, how does that competitive model work?
Well, a lot of times what's happening with profits, and one of the reasons that you're seeing in some of the other market segments, some rate changes that are different, is that the fee-for-service savings that CalPERS is retaining in a fully insured product, the carrier would be retaining as profit. So that's why I'm saying CalPERS is actually who's retaining the profit in this case, as opposed to the carrier. Because in a traditional fully insured product, what's happening is, let's say you negotiate a $700 a month premium for a product. And you say, okay, I'm predicting that you know, 300 is, you know, for capitation, and 300 is for fee for service, and 100 is for this, that, and right. So you've somehow broken it down. If you've predicted that $300 is for fee for service, but because of whatever happened, and maybe in this case it's COVID, only $150 was actually spent on average per member per month for fee for service, then that is withheld by the carrier's profit. And that actually counts against their medical loss ratio because they didn't actually spend it. And then in the individual and small group market, as you alluded to, they actually owe that back to their purchasers as rebates because they have to spend it. But because we flex fund and we don't actually give the carriers that money, we retain it and we pay the fee for service claims directly, they actually can't float their profits up and down because CalPERS retains that money. And so that's why it's static. Whatever they can make on us doesn't change. So that globally in the market, in the fully insured market, it can go up and down. And that's why you see these big swings in the quarterly profits because the patterns of healthcare change, but that's because they can take in the profits associated with lower utilization, whereas CalPERS gets to keep those profits associated with lower utilization as opposed to the carrier because of the nature of the products that we've designed.
I understand how that model works. I guess where I'm a little bit confused or I'd like more information is really understanding how we go about verifying the fee-for-service payments and what goes into that. Because there might be additional costs in that.
To the providers? To the fee-for-service payments to the providers?
Mm-hmm.
Oh, they bill us directly. The providers bill us directly.
Right. No, I understand that.
Oh.
We'll talk offline. I would like to get some additional information.
Okay, I'd be more than happy to.
Thank you.
Yeah.
Did Rob go offline?
I don't see him.
It's all you, Ramon.
Are you, Ramon?
I think
he's coming online right now.
Okay, yes, because we have one more board member wanted to speak, I think.
You have not entered any numbers. Please re-enter your...
Very good. Well, it booted me off, so I'm going to have to go back on the phone. I don't have anybody else on my
I think
list
Karen,
from the board, but I know.
I think Karen Green still wanted to speak. Is that correct?
Okay, Karen Green Ross, please, while I try and rehook.
Sure. And I just had a quick question, which I do not expect Don or Marta to have the answer to, but just something we should think about going forward is always another variable that's likely to impact future healthcare costs, particularly for Medicare, was the recent approval, controversial as it was, for the FDA to approve the new first drug to target Alzheimer's disease, which I'm sure a significant portion of our beneficiaries unfortunately have to worry about or deal with, or their family members. And it's a potential cost disruptor because of the pressure of the expensive tests. Advocates may be pressuring purchasers for the cost, to cover the cost to assess it. So I just think I was just going to, add that to sort of David Miller's questions about long-term effects of COVID and other things we're looking at going forward. I think we probably should have to, unfortunately, look at the impacts of that recent decision and what that might mean for our costs going forward. So I was just wanted to just mention that, because when David brought his questions up, I was thinking about that recent articles I've just read about that approval.
Yeah, it's a great point. As you know, there are sort of mixed reviews as to efficacy. It's not cheap. You know, we will presumably know more now that it's approved in the as we watch experience, but we'll also need to watch it as both a potential cost driver or as a potential cost saver if it's effective and delays the symptoms of dementia.
Great. And then just again, thank you for everybody for all the hard work that we know goes into all this work with the rates and trying to keep the cost down for everybody. So thank you.
Thank you. I don't have anything left in my chat room. Mr. Rubalcaba, is anybody after Ms. Green-Ross?
That's all I have.
Very good. Thank you. Now, I know we have a number of callers from the public. Mr. Fox, please.
Yes, Mr. Chair, we have 10 callers on the line. The first of which will be Lisa Bocas from SEIU.
Hear me? Hello, can you hear me?
Yes, we can hear you.
Okay, great. My question is, I'm Lisa Bocas. I'm from SEIU Local 1000. I live in Shasta County. There was mention in the past about a new option for Shasta and Lassen counties. I believe it was Blue Shield EPO. Is that still an option for us upcoming? And when will we have information before open enrollment on cost and networking so we can make an educated choice on what's going to be the best plan for our members?
Ms. Green?
Yes, so that's part of the Blue Shield Access Plus expansion. So if you look at the Access Plus,
okay.
Yes, yes.
Okay, perfect. Thank you. That was my only question.
You're welcome.
Very good. Thank you.
To answer the question about when you'll have costs, we'll have so regional rates should be in the the rates
Preliminary regionals are in the rate sheets for June. Final regionals will be in the rate sheets for July, but preliminaries are in the rate sheets for June.
That'll give you price information.
Thank you, Mr. Fox.
Yes, Mr. Chair, we have Ann Hollander from RPEA.
Thank you. I want to first of all thank the board and the committee members for your work and dedication. And of course, the CalPERS health staff for doing all the work that you're doing. I do have a few comments about the PPO plans, and I am alarmed with the amount of increase that are in the PPOs compared to the other plans that are PPO and HMO. It is very disturbing that, we have over 10% increase. But one of the things we have to keep in mind is the high quality, affordable health care, and that's one of my goals. I wanted to make a couple comments about the PPO basic plan. If you will recall, and many of you are new members on the board and the committee, and going back to Kathleen Donison, excess reserve funds have been used to the double-digit percentage increases to subsidize the PERS Care Basic Plan. And so it has been continually propped up for years. And I know this is to be true since I follow all this along. But also, it seems that I'm losing my train of thought. I apologize. Also, the rates are coming down. If you were in PERS Care, you didn't change to a platinum, you would be getting a reduction of $168.74 a month, which does not adjust for regional pricing, which is always higher. And the folks in the PERS Choice Plan would be paying $93.90 additional, and the folks in PERS Select, which is still an 80-20, not a 90-10, would be paying $120.88 a month more. And it seems to me that perhaps there could be some adjustment so that you're not chasing all your PERS Choice folks away. It's a a major hit to them. I know there's 5.5 times more people in PERS Choice and PERS Care, but it is a significant change for those folks to go into this platinum plan. And with the regional pricing, it's probably going to be astronomical. So I do want to make that comment. And some of the funds that were excess reserve funds, I might add, some of that money should have gone back to the Medicare plans, PPO Medicare plans, and very little went. I think maybe I understood from one person it was $19,000. Very little compared to the basic PPO PERS Care plan. Then I wanted to mention the Medicare supplemental plans. There's very little difference between a PERS Choice design plan and the PERS Care, which is now going to be combined into the platinum plan. There's very, very little difference in the benefits. And yet, why would I be wanting to pay $36.07 a month more for the platinum plan for my PERS Choice plan, my Medicare, that is, plan? I know you have 3 other Medicare plans you're adding, which I commend the staff, but I don't really want to chase away our members. And it looks like there was an 8.81% snapback, too. So if you look at the PERS Care folks, they'd only be paying $4.79 more than they're paying now. So if you really look at it, I think things should be evened out more among the plans so that you're not chasing folks away, that you're keeping the members there. I know you have fee-for-service and all that, and I find it hard to believe that PERS Choice and PERS Select is just have so many more claims than the PERS Care plan. I just don't understand that, other than maybe the number of people in it. But it does seem significantly higher than I've seen, 15.2% premium change for PERS Choice. It would be 22.92 for the basic plans and 15.71 for the PERS Choice Medicare and 9.66 for the PERS Select. And I know you're doing your best, but it seems like you could do more. I think more could be done to make this work better. I don't really want to change my plan, but I'm going to look around, and I may look around outside of PERS Care or PERS Choice and PERS, whatever I have right now. I think it's Choice, sorry. But I think this is very important to keep that in mind when you look for your self-funded plan. It's not competitive with the other plans out there. And I know it's a tough challenge for you, but we really should do better. So thank you again for your time. I appreciate it. And I hope you can take this into consideration in your rate development. Thank you.
Thank you. Mr. Fox.
Mr. Chair, next we have Alexandra Kachef.
Awesome. Hi, my name is Alexandra. Can you hear me?
We can.
Excellent. Thank you so much. Pleasure to speak to the board today. I'm calling on behalf of SEIU and then also a member of CalPERS, work at the Department of Education. I currently went 2 years ago. I'm calling not primarily because I have a question, but to give you some background and statement on how healthcare impacts your members. About 2 years ago, I'm 33, and about 2 years ago, I was diagnosed with cancer, and then it proceeded to evolve into a stage 4 cancer situation, and I'm in the process of fighting it and actually recovering from that. So I'm very grateful to have the healthcare that I have. In the process, I went from a normal, healthy 33-year-old to somebody who's dealing with a chronic, potentially lifelong condition. And in that process, I learned what the difference was between somebody who was using a deductible on an annual basis and someone who had generally good health to someone with a chronic condition. As far as impact goes, the changes to healthcare plans, I use a PPO and not an HMO because I'm using a lot of specialized treatment. So in that way, access has actually been really helpful. But on the flip side, I'm spending 10 to 20% of my income on gross income, not net, on not only costs not provided by, on all costs that are related to insurance but not covered. So let's say deductibles, doctor's visits, things of that nature. In addition to that, there's costs outside of insurance that I've had to provide fundraisers for. And in addition to that, I've had costs that were run through pre-approval but were not pre-authorized. And I had like bills up to $5,800 show up on my doorstep that I had to go through an appeals process for over a year. Someone with my skills and abilities to navigate the medical system, I'm a certified project manager and I also deal with student data. I have been able to navigate it, but dealing with treatment plus having to navigate a difficult health system plus having costs on top of that, I would encourage the board to really consider the adjustments and the rates for their members. For example, what is now going to be called PERS Gold is not accepted through several providers within the Sacramento area, and that would be a significant cost reduction for me on an annual basis if I could get care through that insurance plan versus what is now going to be called the PERS Platinum. Though I can see that there is effort to change and increase coverage and cost and reduce costs that way, the overall general impact that I wanted to kind of state here is that you have a lot of chronic members, not only members who are working, but members who are also in retirement, who are participating, and they're maxing out their deductibles on an annual basis because they have to deal with the services on a regular basis. So the more effort that we can make to reduce the monthly rate or potentially the deductible size is very helpful. One of the things I found out is that by maxing out the deductible, the monthly rate doesn't necessarily, let's say, matter too much. So let's say I have 90/10 coverage while my rate is a bit higher. At the end of the day, if I am maxing out my deductible, my cost at the end of the day out of pocket is close to the same. It's more about where do I want to pay it, not so much that the cost is significantly less or significantly less impact. So I'm hoping that some of that information can go into consideration as you're looking at your rates, is that when you're looking at people who are high risk, and the reason why they're in certain buckets, primarily it's because on a monthly basis it's affordable, and if they had to increase their costs, it would take away from their resources on a regular ongoing basis. And that ongoing kind of burden is actually the biggest burden for someone in my condition, or someone with, let's say, diabetes, or someone with lupus, or someone who has working an 8-hour job and they're in good stable condition, but they're having to deal with health services that are more costly than, let's say, somebody who's just going in for regular checkups. So I just wanted to be a voice on this call for anybody who is dealing with those situations, that be considered, and that there are probably more people that are working on staff. I don't have, obviously, the statistics, but there's probably more people on staff and employees that are dealing with conditions like this.
Your time has expired, ma'am.
Thank you so much.
Thank you. Mr. Fox.
Mr. Chair, next we have Mr. Tim Behrens from CSR.
Hello?
Yes, sir.
Yeah, good afternoon. Chairman Fechner, thank you for the opportunity to comment. CSR acknowledges the many challenges of assessing the true costs of healthcare and negotiating reasonable rates during the COVID pandemic. We really appreciate the efforts of the CalPERS health team, especially with the expansion of plans geographically in the state and the offering of some new plans. However, we believe there is strong evidence that rate increases should be minimal, remain roughly the same, or even be lowered in some cases for 2022. I really like what Dr. Mountain said his comments on creating more competition. Let's use CalPERS purchasing power as leverage with healthcare providers, because some of them don't seem to understand what creating a partnership means. And with that, CSR's Chair of Health Benefits Committee, Larry Woodson, will present more detailed support for our position. Thank you.
Thank you. Mr. Fox, please.
Yes, Mr. Chair. Next, we have Mr. Larry Woodson from CSR.
Good afternoon, Larry Woodson, CSR. Can you hear me okay?
I hear you just fine.
Great. Well, I'd first like to thank you, Mr. Fechner, for the opportunity to comment and for your initial comments, as well as some of the other board members' comments. And I'd also like to thank Dr. Moles and Marta. Marta, a really good presentation to us at an initial special stakeholders briefing, and then we were allowed some time to caucus among ourselves as stakeholders. Appreciate that very much. First, I think the Medicare rates that are presented here are reasonable overall. Probably for one reason, the Medicare Advantage plans are highly profitable to the carriers. But the HMO rates is another matter. They're much higher that my research into the latest cost data for 2020 and 21 nationally and in California would justify. I'm going to begin with the general landscape of healthcare costs. California carriers achieved massive profits for much of 2020 when elective procedures were postponed due to COVID, and that carried over into 2021 with a spike in COVID in January through March. As Dr. Moles pointed out, utilization has increased, but it's increased slowly from my sources and not to the same levels according to health articles I've found. Federal subsidies to hospitals due to COVID costs helped offset high hospital costs. And a well-respected actuary, Dave Dillon, is a fellow in the American Society of Actuaries. He states that insurance rates should stay about the same in 2022. He estimates that the highest increases, and he acknowledges it will vary, but the highest increase should be no higher than 4%, and about a 4% decrease on the other side and balance out to around 0. Well, United Healthcare is double that with over 8%. And also the average increase for HMOs is 4.83%, which is way too high. That's higher than last year's percent increase of 4.44. Looking at the financial landscape of the carriers and CalPERS universe of plans, and I know I'm going to be redundant here. I appreciate Stacey Oliver's comments. I'm going to begin with United Health. In the just released Fortune 500 list, United Health Group jumped from 7th to 5th this year. Their revenue increased 6.2% over last year. And in spite of costs of covering COVID patients, United Health Group profits jumped 11.3% or $15.4 billion in 2020. Now, this was due largely to profits from Optum and their Medicare Advantage plans. And I also found that they're doing quite well in 2021 with a whopping first quarter profit jump of 44%. So they don't need our 8% an 8% increase with these kind of profits. And I understand Marta's explanation, but the big picture is they're doing well. Blue Shield of California, they reported profits increase of 3.1% over 2019. Kaiser Permanente remained well in the black in spite of COVID in 2020 with a net income or profit of $6.4 billion. They continue to do well in 21 with a first quarter profit of $2 billion. As CalPERS, I think it was Ms. Oliveras pointed out during the meeting last year, Kaiser has an enormous reserve fund for a nonprofit. Lastly, Anthem Blue Cross moved up to 23rd on the Fortune 500 with an 16.9% increase in revenues. To address some specific preliminary rate increases, I'll start with the PPO self-funded. I'm glad to see that the rates for Platinum and Gold did come in slightly less than the November projections, and I understand the concerns of some of the contract employees who don't have as good a plan as the state retirees. But the rates for United Healthcare at 8.9% are unacceptably high. While the drug costs may have driven them up some, it's a 6.9% increase in medical costs that's the main driver. And you know, that really is suspect given all the profits they made during the year because of delayed elective procedures. And HMO Select 772% really raises the red flag. Again, their main driver is medical costs, and that seems to be across the board. Medical costs are the main driver, not drug costs increases. And I don't think that is correct. I think CalPERS needs to really examine that closely. And finally, I hope the board, and I believe they will, have said so in their comments, but I recognize that these are truly preliminary rates, and that the staff goes back and in July we see some more reasonable final rates on those that have such excessive increases. So thank you for your time.
Thank you. Mr. Fox?
Yes, Mr. Chair. Next, we have Mr. Jared Ramey from SEIU.
Thank you. Hello, my name is Jared Ramey. I live in Shasta County. I am a state employee. I have the PPO system to choose from, which is not very good because it's Anthem Blue Cross. They are a monopoly here in Northern California. They provide poor service at a high cost. I have a chronic mental health condition. I am bipolar. I have severe PTSD and severe anxiety. Sometimes it puts me to the point where I cannot work. During COVID, I had three emergency room visits plus a stay in mental health. I have probably bills that total between $8,000 to $10,000 from last year. My biggest problem is the coinsurance that we have to pay with the PPO, and I was wondering if that would be going away with the new system. I spend probably between $250 to $300 a month on healthcare costs. That does not go towards my coinsurance. Those are doctor's visits, therapist visits, and my out-of-pocket medical expenses for my medication. I am also a non-straight passing LGBTQ person, so finding an LGBTQ-friendly doctor in this very homophobic environment is very difficult for me. I went through over 10 doctors before I found a primary care doctor that was LGBTQ-friendly, and I probably called 30 to 40 doctors on the list that they said that Anthem provided me that said we're taking new patients. More than half of those people I called were either one, no longer taking our insurance, or they were not taking new patients, or they were not LGBTQ friendly. That is all I have to say. Thank you for your time.
Thank you. Mr. Fox, please.
Mr. Chair, the next caller is Debbie Gibson from SEIU.
Hi, this is Debbie. Hi, this is Debbie. Can you hear me?
Yes, we can hear you.
Okay. My name's Debbie Gibson. I'm from SEIU, and I actually also live in a rural area. And I was wondering, I've noticed more and more the providers aren't out of network. So I was wondering, what is CalPERS doing to elevate the out-of-network doctors versus the network doctors? So like I had a specialist for a while, endocrinologist, and I go there and, oh, we're not in your network anymore, but you can still come here and just pay out of pocket and then I therefore don't have the benefit even though I have insurance. So I was wondering, is there anything being done to evaluate that as doctors drop out of network and there's less and less for us to even choose from as a available provider?
Anything else, ma'am?
No, I would just like to make sure that that's evaluated because I am in a PPO as well. There is not an HMO as an option, and I don't know what the answer is when a doctor can choose to be out of network, but then that's the only doctor that we have a choice to go to. So I'd like for that to be evaluated in the new contract. Thank you.
Thank you. Mr. Fox.
Yes, Mr. Chair, we have Polly Coughlin, a state employee.
Hi, yes, I am from SEIU as well. My name is Polly Coughlin. I live in West Sacramento, and these are my concerns. In the past, I have gone to a doctor at a facility that was covered, thinking that the normal wellness routine procedure was covered, and I confirmed with the doctor. That's one of the questions I ask whenever I go to a doctor's. I want to make sure that it's covered. And I instead got a bill for $600 for an annual mammogram. When I appealed it, they denied it. And CalPERS said I should call the insurance company directly and negotiate for a better price, which they did not do. So I ended up paying the $600 for a routine wellness mammogram. In December of 2020, I called to ask what mammogram provider is covered. They didn't have anyone. And again, I live in Sacramento. Finally, I told them that I asked if I went to UC Davis, would that be covered? And it was covered. I also damaged my foot and I went to urgent care. And again, I got a bill saying that the services were not covered. When I called to find out why I was getting billed for it, they said that because it was an emergency, they would cover it. But this was only after I called. Last year, I switched to an HMO. I pay $130 more a month because I was scared that if I went to a doctor under COVID, if I ever got COVID and I had to go to emergency room and see a doctor, I would get gigantic bills that were not covered and I wouldn't be able to afford to pay. So I had PPO CalPERS Select, and now I have switched to a Blue Shield HMO Trio. And those are my concerns. Thank you.
Thank you. Mr. Fox?
Yes, Mr. Chair, the next caller is JJ Jelensik.
Hi, this is JJ Jelensik. I'm Health Director for RPEA. I want to say something you've never heard me say before during rate negotiations. The rates are too damn high. I also recognize that it is a national problem, not a CalPERS problem. I'm hearing a lot of static. Are you hearing me?
Yes, we can hear you.
Okay, thank you. MIRA uses cost, which is fees times usage, to measure risk, and they're trying to equalize the risk. And that works if all of the vendors have the same fees, but that's not the case here. All plans have a different fee schedule, with the exception of Medicare. I had said the intent was to protect the insurance companies and to score high and to save high-cost plans. I was told I was wrong. Parenthetically, sometimes something I'm used to hearing, although it's common for my comments to come back from others a year later. But look at what's going on here. And I want to start with the basic plans because many of our members are not Medicare eligible. If you look at the plans, Anthem Traditional gets a $98 a month subsidy for the 13,000 people in it. Blue Shield Access Plus, $117 a month subsidy for the 8,000 people in it. The 560,000 people in Kaiser are going to pay an additional $22 a month to help offset that. The people in Sharp are going to pay basically $41 a month to help subsidize that. There is if you look at the subsidies, it actually goes, we're subsidizing the high cost plans to save the low cost plans. When you look at PERS Care Basic, PERS, or the PPO, PERS Care Basic is the 25,000 people in that are going to get $133 a month savings. To finance that, the 142,000 people in choice are going to pay an extra $94, and the 110,000 people in select are going to pay an extra $121. It's really about protecting that high cost plan. On the supplemental side, quite frankly, the HMOs are too high, but they're at least reasonable. But if you look at the PPOs, the 66,000 people in care are going to pay an extra $5. The 79,000 people who were in choice are now being moved to platinum are going to pay $36, and the 3,000 people in select are going to pay an additional $26 a month. Part of the problem with this is that it really encourages the vendors to pay higher fees. Because of the way it's being calculated, if you increase the amount that you pay in fees, you will get a higher risk score, even though nothing else has changed, and you will get a greater subsidy. You really need to rethink how you are doing this risk adjustment. For this year, it's baked in, but give some real thought to whether this is, in fact, the road you want to continue on next year. And you have previously indicated that right now you're just treating the HMOs as a group. Your plan is to treat the HMOs and the PPOs in the same risk pool, although we've heard today consistently that PPOs are much more expensive because of the fact that there's greater use of specialists and greater use general. So I thank you for your time. I ask you to really rethink whether this is the route you want to go. Thank you.
Thank you. Mr. Fox.
Mr. Chair, the last caller is Maria Blaine, a CalPERS member.
Hello, everyone. Thank you for taking my call. I'm calling on behalf of, I work for the state of California, and I'm a member of SEIU. I'm calling on behalf of a member. She is unable to be here today and make the comment, but she's working as a teacher at Pelican Bay del Norte. Her insurance is a PPO. Currently, her claims from a March hospitalizations are being denied as not network, not pre-approved, and not an emergency. She is facing a $265,000 bill because Anthem is telling her that it's her responsibility to pay. The member was airlifted by ambulance to the only available hospital that was taking patients during the pandemic. She was also receiving intravenous pain medication and assumed that the doctor and hospital staff were representing her best interest and doing their diligence or prerequisite part in assuring prompt payment from the insurance companies. Also, this is not the first case we hear about this, and it is not the first issue that we've heard in this meeting. Please also know that the member had to take an Uber home after being discharged from the hospital from her surgery. It was a 325-mile tour or a 6-hour drive. There was no compensation for that. It was just not a pocket expense. The total monthly payments per person for medical insurance is too high. The member is currently doing all the work and spending countless of hours coordinating the bills in order to appeal and do the medical work necessary to receive some kind of relief. So we have a follow-up question are you tracking out-of-network costs that these members are forced to pay and are dealing with? That just amounts to high level of stress and anxiety, contributing to the detriment of their physical health? Thank you for taking my call.
Thank you. That is Mr. Fox. Is that the last caller?
Yes, Mr. Chair, that was the last caller.
Thank you. Well, we heard a trend in a lot of those calls, and I will say that Mr. Moulds and Ms. Green, I did tell you that we met with SEIU a week ago and heard a lot of these concerns about the out-of-network, et cetera. Asked for backup information with plans, et cetera, so we could pass that on to you, because we want to make sure our members are protected. We have yet to hear anything in regards to that conversation. So although I heard the members today, we have heard that. We're waiting for information so that we can make sure that we can start pushing the buttons on our end. With that, I have Ms. Middleton.
Okay, thank you, Mr. Chair. I want to respond a bit to the gentleman from Shasta County who spoke. I first started with the state of California in 1974. I can tell you in the 47 years that have transpired for those of us in the LGBTQ plus community, our access to culturally competent healthcare has changed from night to day. Things have improved tremendously. But that is most particularly true in metropolitan communities and in larger communities. And I know that Dr. Logan, Dr. Moulds, Ms. Green have just done exceptional work. But access to culturally competent healthcare across the state is something that is incredibly important. Individuals within the LGBTQ community defer and avoid accessing healthcare frequently because they fear facing discrimination. Most of us in my community can recount one or more instances of discriminatory or just blatantly unprofessional conduct that we have encountered in medical offices at some point in our life. So everything that we can take and do to ensure that we make it easier for our members who are within the LGBTQ community, particularly in rural areas, have access to culturally competent healthcare is something that is really important. And thank you.
Thank you. Seeing no other requests to speak, Ms. Green, anything else you'd like to add?
No, thank you. Thank you, Chairman.
Great. Well, again, thank you for a great presentation and thank your entire team. Mr. Moulds, anything else on this agenda item?
Nothing from me. Thank you, Mr. Chair.
All right. Next agenda item is the summary of committee direction. Mr. Moulds?
I have two items. The first is to ask Dr. Logan to speak about long COVID and longer term effects of COVID in a future COVID update to the board. And the other one is to continue monitoring Adjourn, which is the new Alzheimer's drug that was just approved by the FDA, both for increased new evidence about to shed more light on efficacy as well as on the cost side, which we will continue to do and are happy to report back to the board as we learn more.
Thank you. And I would like to add as part of committee direction that we want to look at the plans and whether or not they're giving the right information, if they have the right doctors out there, whether or not they have enough doctors, and whether they're sending people out of network when they shouldn't be. So I want to make sure we're keeping our tabs on that. And as well, I know it's not for you, but it was committee direction that those plans that have not partnered with you and your team need to by July. So I know that's not your direction, but that's my direction to the plans. So seeing nothing else, Ms. Middleton, when would you like to start risk and audit?
I think everyone could use a break. It's 3:15 now. Let's start risk and audit, which will begin in open session at 3:30.
Very good. Well, we thank everybody for your attention today, and we will see you at risk and audit at 3:30. This meeting is adjourned.
call the June 15 Risk and Audit Committee to order, and let us begin with the roll call, please.
Lisa Middleton,
Present.
Margaret Brown, not yet appeared. Frank Ruffino for Fiona Ma.
Present.
David Miller.
Here.
Shonda Wesley. I see her name, but I do not hear her. Lynn Paquin for Betty Yee.
Here.
Last call, Shonda Wesley. Madam Chair, I have everyone in attendance with the exclusion of Margaret Brown, not yet, and Shonda Wesley appears to be in the meeting, but I do not see her video.
Do we have a quorum?
Matt.
Yes, you do.
All right, thank you. Then we will go ahead and proceed. Second item on the agenda is approval of the June 15 Risk and Audit Committee timed agenda. Is there a motion to approve?
Move approval.
Mr. Miller, second.
Second.
Lynn Paquin for Betty Yee. Roll call, please.
Again, Margaret Brown.
Aye.
Frank Ruffino for Fiona Ma.
Aye.
David Miller.
Aye.
Shonda Wesley. Lynn Paquin for Betty Yee.
Aye.
Madam Chair, I have a motion being made by David Miller, seconded by Lynn Paquin for Betty Yee. I have 4 ayes. Shonda Wesley's not in appearance right now. So I believe that is the votes we have currently.
Thank you. Ms. Timberlake Diamano, would you like to give the executive report?
Yes, thank you. Good afternoon, Madam Chair, Mr. Vice Chair, committee and board members. Marlene Timberlake Diadamo, CalPERS team member. We have 2 audit action items for your consideration today. The first is the 2021-2022 Office of Audit Services Plan. The Office of Audit Services will present its proposed annual audit covering audits and activities to be performed in fiscal year 21-22. The second audit action item is the independent auditor's annual plan. The independent auditor will present its annual plan to provide information on its approach, scope, objectives, and deliverables. At the conclusion of the audit, the independent auditor will report the results of the audit and express opinions on the respective financial statements of the fiduciary and proprietary activities. The 2021 annual compliance plan will be presented as an information item. The annual compliance report, excuse me, I said plan, but the annual compliance report reports on information items summarizes CalPERS in enterprise-wide compliance activities for fiscal year 2021. The next Risk and Audit Committee meeting will take place in September 2021 and will include the Enterprise Risk Management Framework Review. Thank you, Madam Chair. This concludes my report, and I would be happy to take any questions.
Okay. If I could add a comment to Ms. Timberlake Diamano. Recently, Ms. Brown requested a discussion of the audit review of death benefits receivable. Since that topic had not been agendized for discussion at this meeting, and November is a full 5 months out. After conferring with staff, most of the agenda planned for the November meeting will actually be held in September. We will have a Risk and Audit Committee meeting in September. There will also be a November meeting of the Risk and Audit Committee meeting, as that meeting is necessary and very important to review the independent auditor's report and management letter. Are there any questions regarding that? Margaret, Ms. Brown?
Yeah, I saw I put something in the chat. So, so we will be taking up the agendizing the audit for September or for November?
September.
Thank you. I really appreciate you doing that. Thank you.
You're welcome. And the big thanks goes to all of our staff who were very accommodating and working through. With that, we will move on to action consent items. Approval of the April 19, 2021 Risk and Audit Committee meeting minutes. Is there a motion?
Move approve.
Mr. Miller, approve. Second?
Second.
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 I think I heard Ms. Brown first. So roll call, please.
Margaret Brown?
Aye.
Frank Ruffino for Fiona Ma?
Aye.
David Miller?
Aye.
Shonda Wesley?
Aye.
Lynn Paquin for Betty Yee?
Aye.
Madam Chair, I have a motion being made by David Miller, seconded by Margaret Brown for agenda item 4A, approval of the April 19, 2021 Risk and Audit meeting minutes.
Next item on our agenda is item 5, information consent items. Is there any discussion or questions on the information consent items? Seeing none, can I get a motion to approve item 5?
Move approval. Second.
Mr. Miller moving, Mr. Ruffino seconding. Roll call, please.
What item was this for?
This is number 5.
Okay, those are information consent items?
Not required?
Not required.
Thank you. Then we will move on to item 6A, which is the 2021 Office of Audit Services Plan. Ms. Chapuis. There she is.
All right, I was just allowed to join. I could watch everyone, but I couldn't see myself there. Good afternoon, Madam Chair and members of the committee. Elise Chapuis, Office of Audit Services. Agenda item 6A is an action item. Staff is requesting the Risk and Audit Committee to approve the Office of Audit Services proposed audit plan for the fiscal year 2021-22. As required by the internal auditing standards, the Office of Audit Services prepared the risk-based audit plan to determine the priorities of the internal audit activity for the next fiscal year. In conducting the risk assessment, the Office of Audit Services, as the third line of defense, coordinated its efforts with the second line of defense, Enterprise Compliance Division, and Enterprise Risk Management Division. We interviewed CalPERS executive and senior management teams and sought input from the board members through surveys. Staff also incorporated information from prior audits. Office of Audit Services has 2 audit programs, internal audits and employer compliance reviews. In identifying the internal audit assignments and activities, staff evaluated multiple risk factors such as impact on the organization's strategic goals and financial statements, changes in the operations and regulations, and internal controls. We also allocated resources to consulting engagements and special projects. For the employer compliance reviews, the Office of Audit Services plans to complete 4 review cycles covering 1 compliance area per cycle and 60 to 80 agencies each cycle. As required by the internal auditing standards, will remain responsive to the changes in the organization's operations and programs, and we will review and update the audit plan as necessary. Any modifications to the audit plan will be communicated to the committee through the quarterly status reports. This concludes my presentation, and I'm happy to answer any questions.
Are there any questions for Ms. Chapuis? I don't see any, but I would like to congratulate you on what looks to be a very well-rounded plan for the upcoming year. And you've got, I think, a number of very important audits ahead of you. I do see Ms. Brown has a question.
Yeah, it's a question and a statement, and you know, I was going to make a motion or ask for an amendment to the motion to that we put the audits on the open session agenda. But since it looks like, you know, we're doing that with the review of the death benefit overpayments, that it looks like going through what I'll consider to be a normal process, which is asking the chair and then getting on the agenda. I don't think it's necessary to have that as part of the audit plan, that audits are automatically put on the consent agenda. Last year, we did that, but we said we would put it on the closed session agenda, and legal counsel has struck that down as not, didn't comply with the exceptions. And so I was going to ask that it be part of the open session, but since now, Ms. Middleton, it looks like we've struck gold here. We're going to get audit on the open session agenda when they're critical. I'm not going to make that suggestion, but I just want you to know I was planning on doing that, but thank you for that.
Thank you. Ms. Chapui, I want to ask just a couple of very broad questions that and these are different, differently phrased than what you will receive in closed session, because I want to get this out into the public. Whose responsibility is it to ultimately develop the audit plan that you present to the board?
It's mine.
And
I work with my managers in developing that. And as we stated, we work with the executive team, the board members, division chiefs, and identifying the risk areas for the organization. And there's a universe of assignments that we could perform, of course, with the resources and time we have available. We just identify the ones that bubble up to the top that we could perform, and we put it on the plan that we present to the Risk and Audit Committee, and it's my and my team's responsibility to develop that plan.
Since many people are not familiar with the process, could you just very briefly go over what you do in terms of reaching out to individuals outside of your team to get their ideas as to what should go into the audit plan, and then how you work with your team to come to the ultimate conclusions?
Absolutely, absolutely. As we're expected to perform a risk-based audit plan pursuant to the standards, we have a universe that we could call, right? All the assignments that OFAS could possibly perform for the organization. But for us to narrow it down, we conduct these meetings in person with the executive team, one-on-one. We meet with every single one of them individually, myself and the representatives of the second line of defense, enterprise compliance division, and enterprise risk management. So we do this as an integrated assurance team. And we meet with them, we seek their input. We also send them a survey in advance for them to think through the questions, and some of them choose to respond to us in writing. Some prefer to respond to our questions in person when we meet with them. And we also do the same thing with the division chiefs. And to the board members, we send a survey. And thank you to those who had the opportunity to respond to us. We take those responses very seriously. We like to incorporate everyone's input into the risk assessment, but ultimately it's really the auditor's responsibility to determine those assignments, because we have a well-established knowledge of the potential audits, potential risks for the organization based on the assignments we've performed in the past. But we would also like to incorporate these developing risks. Everything changes on a regular basis on a daily basis. So we do have to refresh that risk assessment as we go, as we develop the audit plan every year.
All right, thank you. So I appreciate you doing that. And it is critical to your independence that that you continue to reach out, but ultimately the final decision is yours. With that, this is an action item. Can I get a motion to approve?
Move that we approve the motion to approve the Office of Audit Services plan presented by Ms. Chapui.
Okay, is there a second?
Second.
Okay, second, Ms. Brown. Roll call, please.
Margaret Brown.
Aye.
Frank Ruffino for Fiona Ma.
Aye.
David Miller.
Aye.
Shonda Wesley.
Aye.
Lynn Paquin for Betty Yee.
Aye.
Madam Chair, I have all ayes. Motion being made by David Miller, seconded by Margaret Brown for agenda item 6A, 2021-22 Office Audit Services Plan.
Thank you. We'll move on now to item 6B, the Independent Auditor's Annual Plan. Ms. Chapui.
Good afternoon, Madam Chair and members of the committee. Belize Chapui, Office of Audit Services. Agenda item 6B is an action item. Staff is requesting the Risk and Audit Committee to approve the board's independent auditor, BDO's audit plan for the audit of CalPERS' financial statements for the fiscal year ending June 30, 2021. The presentation is to provide the Risk and Audit Committee the opportunity to hear from the independent auditor regarding their approach, objectives, scope, and deliverables for the financial statement audit, and enable the committee to ask questions. BDO staff are presenting with me today, and I would like to turn it over to them.
All right.
Lee?
I see Mr. Kim.
Yes, good afternoon. Can you hear me?
We can.
Okay. Can we make sure my colleagues are also elevated if possible? Steve Franklin, Sylvia Mack, and Deepika Nagan as well. Thank you. All right. Good afternoon, Madam Chair, Vice Chair, and members of the committee. It's good to see you again. And for the record, my name is Billy Kim, overall BDO engagement leader for the external audit of CalPERS. I'm joined here with my colleague, Steve Franklin, who is our Assurance Bay Area Financial Services practice leader and is responsible for assisting me in leading the audit of the investments area. I'm also joined by Sylvia Mack, who is an assurance director, and Deepika Nagan, who is a assurance senior manager, and both of whom assist me in leading the overall engagement team, planning, audit approach, strategy, and execution. So for our presentation, we'll walk you through our PowerPoint, which we have prepared, and we'll highlight specific items for your attention. Can we move to slide 5, please? So first off, I want to talk about our client service team. You know, this is an organizational chart of our team, and all the names shown on this slide represent key leaders as well as key specialists on the BDO audit team. And there are also many other people that report to each of these leaders as well. Our overall engagement team has a mix of recurring team members and also new team members. And this really helps us to build off of our knowledge that we gained from the prior year, but also at the same time to help us to continually bring a fresh perspective to the audit work. I also wanted to touch upon our scope of services, responsibilities, and independence. And so can we move to slide 7, please? Thank you. The scope of our services include performing the audit over the 2021 fiscal year ending financial statements of CalPERS, as well as performing the audits of the GASB 68 and GASB 75 employer allocation schedules. And as part of the audit of the financial statements of CalPERS, we will report to you the results of the audit work prior to the issuance of the statements in November. And also at that time, we'll share any internal control recommendations that we identify and also results of any remediation of prior year findings. Next slide, please. This slide, from a financial reporting and audit perspective, lays out the responsibilities of management, but also the Risk and Audit Committee. As a reminder, management is the one that is responsible for preparation and the fair presentation of the financial statements and the schedules in accordance with generally accepted accounting standards. Management is also responsible to provide us, as your auditors, all access to records for us to complete our audit work. The Risk and Audit Committee, as a reminder, is responsible with the oversight and accountability of management over the financial reporting process and also over internal controls over financial reporting. Next slide, please. Now, as your auditors, BDO is responsible to perform an audit and expressing an opinion over such financial statements and schedules in conformity with generally accepted accounting standards. Next slide, please. Now, this slide is on independence and confirms that BDO is independent of CalPERS, which is a requirement under our professional standards. Now I'll pass it off to Deepika, who will go through the next few slides.
Thank you, Billy. May we move to the next slide? One more, please. Thank you. This slide shows the overall timeline for the audit. I did want to highlight that we are in touch with management throughout the year. This is important to us as we continue to ensure we are identifying any changes or information we need for the audit on a timely basis, and also providing real-time audit progress updates to management. We are in the stages of wrapping up our interim testing this month. Management has been very responsive to our requests thus far. We have not had any issues accessing or obtaining access to any information we have asked for, even while we are currently continuing working remotely due to COVID-19. As it relates to work being performed and completed thus far, we have not found any specific issues to report to you. Next slide, please. One more slide, thank you. This slide discusses our audit strategy and risk. I'm going to start with describing some of our audit strategy considerations. As part of our planning process, we have been working to identify areas of focus, including areas of potential misstatement, whether it be due to fraud or error, as well as other areas of concern. We identified those areas by considering prior year results of audit, as well as performing preliminary analytical reviews. We also consider any changes or developments within the industry, as well as changes in the general economic conditions. All of these inform our decisions over materiality, which we continuously assess throughout the audit. We've also thought through areas of judgment and estimate and whether any areas contain higher risk. We've considered the entity's internal controls and have performed walkthroughs to gain an understanding of the process and controls that are in place. As a result of this process, we work to identify if there's any particular areas of risk that would be of concern where we'd want to focus our audit procedures on. Next slide, please. The next slide highlights that even though our planning process was performed as a way to identify areas of risk, this is a continual process. So as we go through the audit, if we identify any other areas of concern, we would focus on that and work to develop audit procedures to address those areas. We will communicate with the Risk and Audit Committee if we see any changes to our planned audit strategy as we progress in our audit. With that, I will pass it on to Steve Franklin to discuss our investment plan.
Can you please go to slide 18? Thank you. Good afternoon, everyone. So as you can see here, I'm going to focus on the investment piece, which is the item number 2 on this slide. And what one of the key procedures that we are going to take is confirmation of the holdings. So we will be sending confirmation of all the securities that CalPERS holds, both the the public securities and also the private equity and real estate securities. We will sending confirmations to the custodians to validate those. We will be also performing detailed valuation procedures over the pricing and valuation of those public securities, as well as the private equity and real estate assets. The private equity and real estate investments, we will be obtaining audited financial statements of those entities as of the latest fiscal year, which would be December 31st, 2020. We will then be obtaining capital statements that CalPERS receives from each of those underlying investment firms on a regular basis, on a quarterly basis, and validate that information and compare that information to the audited financial statements. We will also be doing testing realized gain losses that the funds have been realized during the fiscal year. In addition, we'll be focusing again on the lag analysis, which is the difference between the audited financial statements of the underlying funds for private equity and real estate versus CalPERS year-end, which is as of 6/30. We will also then be doing an analysis and work closely with management around the lag of initially preparing the financial statements as of using the 3/31 information and comparing that to 6/30. So we have a really nice process and work closely with management on that, and have come to to really be efficient and be able to get that nailed down very quickly and precisely. We will do some additional other sampling procedures around as part of the investments around the disclosures and the annual report. But again, we look forward to another really good year. I would say that most of our investment testing is focused on at year end because we want to, test the existence and test the value of the investments as of 6/30. So it doesn't really help us too much to do them as an interim as of now, whereas some of the investments and some of the, the plan accounting has been doing work now. We really focus our work at year end when it's most efficient for us. With that, I'm going to hand it over to Sylvia, who will continue with the audit areas of focus.
Thanks, Steve. So as Topeka had mentioned earlier, part of our main focus for the past month or so and into June has been planning and risk assessment. As part of that process, we have been performing our walkthroughs to gain an understanding of the controls. We've also been inquiring of personnel at CalPERS, not just those in the accounting department, but also those outside of the accounting department to get a better understanding of risks. We will also be sending out external third-party confirmations. We'll also be reviewing the tip line activity. And then as part of our risk assessment, also selecting journal entries by using data analytics to identify whether there's any particular entries we want to focus on particularly. In addition, we're also going to focus on long-term care liability. As part of that review, we will review the actuarial valuation reports, including any key assumptions used. We'll also test the roll forward activity for the year. And we'll also select samples of underlying census data for completeness and accuracy testing that supports the valuation reports. Another area of focus is a healthcare estimated insurance claims due. As part of that, we test the claims for accuracy. We also perform a retrospective review of the prior year incurred but not reported information. We also recalculate the liability amounts as well. The next area of focus is the pension and other post-retirement benefit liabilities and related disclosures. We'll also, in relation to that, test the census data for completeness and accuracy. We also use our in-house actuarial professionals to help evaluate the reasonableness of assumptions used based on published data and most recent experience studies. We'll also do recalculations, including modeling long-term rates of return to evaluate sufficiency as well of the net position calculations. As it relates to plan contributions, we do select a sample of recorded contributions during the year and perform recalculations of the required contribution rates. And we'll also use data analytics to help identify any contribution anomalies for further investigation. Benefit payments are another area of focus, where we also perform a sample selection to ensure that distributions are being made in accordance with plan provisions, and we'll also use data analytics as well to test for any anomalies. Premium revenues is another area of focus where we'll also test for completeness, existence, and accuracy, and we'll also perform particular cutoff procedures as well. And then finally, we also focus on the information systems. We've been working to identify all the systems that are relevant to the financial reporting process. And as part of that, we review for the design and implementation with particular focus on logical access and change management controls, as well as reviewing user control considerations as it relates to any of the key service provider information systems. I'll turn to slide 20. The next couple slides just summarizes some of the available publicly information resources for our clients in the governmental public sector industry. This site gives various tools and resources. And if we go to the next slide, we do have an area on the site that's particularly focused on COVID-19 resources and will help entities stay up to date in terms of the latest developments and areas of consideration to help mitigate risk in the current environment. And if we turn to the next slide, this slide just summarizes our various online resources, including thought leadership, practice aids, tools, and emerging trends that are available, which include webinars if you're interested. So feel free to take a closer look at this and go on the website and get some additional resources. If you have any questions, let us know. And that brings us to the end of our presentation, and we'll open it up for questions.
Great. Thank you, and thank you for a very strong presentation. It is my understanding that you will be taking a focused look at the dormant account program. Is there anything that you would like to say publicly regarding your plans in that area?
Sure. Sylvia, you want to address this one?
Sure. So yes, we are aware of the April press release that was released related to the inappropriate access to particular dormant retiree accounts. We understand there's an ongoing investigation, and as part of our audit, we will continue to stay up to date on the progress of that investigation, as well as from an audit perspective, we will be performing additional procedures in order to address any risks that may arise as part of that.
All right, thank you. Are there questions for BDO? I do not see any, which, and in light of the fact that we do not have any, this is an action item. Can I get a motion to approve?
Move approval.
Mr. Miller, second.
Second.
Second, Ms. Paquin. Roll call, please.
Margaret Brown, did we lose her?
I think we've lost her. I do not see her.
And I do not see her in the attendee list as well.
This is Jared. I think she's on the phone. She's the 949 number.
I
did
not see
unmute her,
that.
so she should be able to speak.
Ms. Hopper, go ahead and try one more time.
Okay, Margaret Brown. I see her in the attendee list, but she has her phone on mute. Frank Ruffino for Fiona Ma.
Aye.
David Miller.
Aye.
Shonda Wesley.
Aye.
Lynn Paquin for Betty Yee.
Aye.
Madam Chair, we have 4 ayes. Motion made by David Miller, seconded by Lynn Paquin for Betty Yee. And that's on agenda item 6B, Independent Auditor's Annual Plan. And one more time, Margaret Brown.
Do not see her. Mr. Miller, you have a comment?
Yeah, I just wanted to say a quick thank you as the former chair of the committee and as still on the committee as vice chair. I've really appreciated working with Billy, Sylvia, Steve, the team, Deepika, and really look forward to a continuing to work with you all and the fine work you've done. And I'm glad to see a very comprehensive plan that really addresses the risks that we're facing, and just looking forward to more and better.
All right.
Thank you,
Thank you
Vice
for
Chair.
that.
Thank you.
Mr. Kim, your team, it's a pleasure always working with you, and we look forward to seeing you in November.
All right, thank you.
With that, we will move on to information items. 7A is the 2021 Annual Compliance Report from Ms. Timberlake Diamano.
Yes, hi, good afternoon again. This is a standing item that we bring to you every year. This is the second year that we've brought it in June. Previously, we brought it in November. And this item is a report of the enterprise-wide compliance and risk management activities that have occurred throughout the enterprise. In the document on slide 2, we have a general letter from me. We talk about culture of compliance. We include the integrated assurance model, which you're all familiar with in terms of our 3 lines of defense. And then we go from pages 5 to 7 on the Enterprise Compliance Office, Compliance and Risk Office. And then beginning on page 8 through 12, we actually include the compliance and risk management activities of our partners in the businesses, including the Actuarial Office, Customer Service and Support, Health Policy and Benefits, Investment Office, Legal Office, and our Operations Branch. So with that, I'd be happy to take any questions if there are any, and this is an information item.
Are there any questions for Ms. Timberlake Diamano? I can't see all of my colleagues, so maybe we could get back to the full gallery. There we go. Thank you. I do not see any questions in the chat, and I don't see any hands being raised. So thank you very much for a really good report, and that will take us to the next agenda item that I've got to turn back to, which is 7B, Summary of Committee Direction.
I did not take any direction.
We didn't give you any, sorry.
There you go.
That's right. Thank you. So that takes us to item 7C, which is public comment. Mr. Fox, do we have any public comment?
Madam Chair, no, there are no callers.
All right. With that, we will be moving into closed session. I am not certain how long the closed session is going to last. We will have a short reporting out in open session at the conclusion of our closed session. And with that, I will ask that we will need to leave these screens and head into the closed session sign on. So I will see everyone virtually in just a moment. Committee met in closed session. There was no reportable actions. And with that, I believe we stand adjourned from Risk and Audit Committee. We will reconvene tomorrow morning at 9 a.m. for the Performance Compensation and Talent Management Committee. And with that, have a good evening, everyone.
Take care.
Thank you.